Yes.
Sir, they said their team is there. So welcome all to the 40th All Kerala Congress of Obstetrics and Gynecology Endoscopy Workshop. Owing to the pandemic, the organizing committee has started an excellent academic program, Faculties of Eminence on virtual setting. So because of the time restriction, there'll be a Q&A session in the end and addressed during the discussion. On that note, may I welcome the Chief Coordinators, Dr. Ashwath and Dr. SUBASH MALLAYA. Can I start sharing? Dr. Ashwath Kumar is a diploma in advanced laparoscopy from France. He's working in Jubilee Mission Medical College. He's a gynec oncology fellowship also, and he's also a diploma in laparoscopic management and advanced endometriosis from Australia. And we also have Dr. SUBASH MALLAYA, who's working in the PVS hospitals and Baby Memorial Hospital in Calicut. And he is also a chairperson elect of the FOGSI Endoscopy Committee 2021 to 23 and the zonal coordinator to FOGSI president. And he's also the award. He has won the award for the FOGSI mentor mentee, and he's published 4 papers in index journals. I request Dr. Ashwath to come all the faculties.
Good evening, everybody. It's a proud privilege for me to welcome you all to AKCOG. Usually we have a live laparoscopy workshop with all our eminent faculties over. So the sad thing is that we cannot have that, but we are having all the faculties together. It's a great to see all the endoscopic surgeons in Kerala, and we are fortunate to witness 2 of the national faculty, great national faculty, young Sujal Munshi and our IAG President KUMAR sir. First of all, I thank our President Ambuja Madam and Secretary Venu for giving us an opportunity for myself and Subash to coordinate this whole program, and thank all the faculty who were willing with more than everybody for the one call itself. They were all ready to do whatever way they can help us. So I'm very happy we have all of them here. Today we have all the faculties. In the first talk we have Sujal Munshi and Jayakrishnan sir. Then we have Hafiz sir and Paul sir. Then we have our IAG President KUMAR sir. Then a wonderful panel by Kurian sir. And we have Chairperson Senior Endoscopic Surgeons of Kerala as chairpersons for the program. So we have Hari Prasad sir, Sam Abraham, Usha, Dr. Usha, Dr. Ajida, and Subash, and MOC, our Dr. Adulya is there, and Medicon Events. We thank everybody and welcome you all, and welcome all the and very happy that more than 100 people are there at the beginning of the program itself. So it's all are enthusiastic, and we have made very simple topics actually. That is the reason why people have logged in to listen to all the great faculties. Without any delay, I request Dr. Adulya to introduce the chairpersons of the first session and hand over mic to the chairpersons.
Yes, sir. Thank you, sir. We'll begin the first session, and we have 2 chairpersons, Dr. Sam Abraham and Dr. Usha Menon. Dr. Sam doing advanced laparoscopy, IVF, ICSI, and sexology procedures. He has won Adhura Seva Awards. He has won the Millennium Excellence Award and even the Gandhi Puraskaram Award. And he's participated in many as a faculty, endoscopic and ultrasound workshops. And Dr. Usha Menon is a diploma from.
Good evening, everybody. I would like to introduce our first speaker, Dr. Sujal Munshi. He's a consultant in endoscopic surgeon, consultant gynecological and endoscopic surgeon from Kalpana Munshi Hospital and Nova IVF, Ahmedabad, and also from PS Medical College, Karnasar. That's what I wrote here. And elected board member. He's an elected board member of IAGE from 2019 to 2021, and he's a past elected MCM of AOGS, and is a course coordinator and in charge for FOGSI ICOG approval training and fellowships at KMH LLP and Indo-French diploma training course at CICE France by Nova IVF. Over to you, sir.
Thank you. If you can permit me to share my screen, the coordinator. Hello.
Sujal, now it's okay. Now it's okay.
No, the video.
Basically, a part of it may get cut. That is what I feel, but still it is okay.
Okay, still it's okay. You can start.
So the topic given to me was simplifying the technique of laparoscopic hysterectomy. I will touch just the basic points, but we should all know how it has evolved. When we look at this beautiful article, past, present, and future of hysterectomy, the mortality in initial few cases was 100%, then it came to 73% in early 1800th century, and now we can hardly think of mortality. That is how the refinement has taken place over period. This is how the technique has evolved. Initially vaginal, few cases abdominal, and then now a refined laparoscopic technique. And thanks to this stalwarts who actually developed this technique, first reported case of total laparoscopic hysterectomy in 1888. Just in a year, radical laparoscopic hysterectomy also took place in 89 in Clermont-Ferrand. From 89 to 90s, the surgical steps were evaluated, the technique got corrected, the uterine manipulator was introduced in 95, and from 2000 to 2021 we have seen the evolution. And thanks to all the surgeons present in panel just now also, they have worked very hard, and we have been seeing sir from operating in early 90s and 2000, from where we have learned these techniques. If you look at current data, which is very similar to Indian data, the overall hysterectomy has gone down, which is seen in the gray scale. But if you look at the type of hysterectomy, there is a steep decline in the abdominal hysterectomy. There is a rise in the vaginal. There is a steep decline in vaginal hysterectomy also. The blue bar, which is showing laparoscopic hysterectomy, is on an ever rise. Unfortunately, we don't have this concise data of India, but the trend is similar, though the numbers may be very high in India. The US statistics are little different because of the popularity of robotics, but still it is proved beyond doubt that laparoscopy is still gold standard. And the reasons are, you have very good tissue imaging with better camera systems now. You have multiple options for meticulous hemostasis. The morbidity has drastically reduced with the minimal invasive surgery, and you always have an option of dealing with adnexal pathology, adhesiolysis, ureterolysis, and now more and more cases of retroperitoneal dissection are being done with laparoscopy. So even American College of Obs and Gynae has clearly now mentioned in their guidelines that there is an edge of minimal invasive surgery as far as hysterectomy is concerned.
The whole thing, because this is accommodating.
So in today's era, the contraindications are only and only insufficient knowledge or training. If you are not well versed with the technique, then it should not be attempted. Otherwise, it is approved technique. And second is medical conditions where general anesthesia or position of the patient because of laparoscopy and pneumoperitoneum is not recommended. Only in those cases you should avoid. Otherwise, in all other cases, it is the preferred modality.
If you put it, your thing will not come.
Actually starts with structured training.
That is the thing.
In structured training, this is as such a very fast video. This is just for this thing, that a standard technique starts with structured training, a good OR setup, correct pair of instruments, proper anesthesia, and standardizing the technique is all what is required. And if at all complication arises, it should be identified properly and treated in time. So let us understand what training is required to perform this. There are more than 40 institutes in India itself. Like you are a resident of Trichur under Dr. ASWATH sir, you are definitely going to have a good exposure of laparoscopic hysterectomy, and there are many other medical colleges. But there are medical colleges where it is not there. So IAGE and ICOG, they are working very hard to deliver this training in institute itself. But if at all you're not lucky and did not have training during this year, you always have good orientation courses to start for 7 to 15 days, accredited by FOXI and IAGE. You have good fellowships of 16 to 18 months, which is the most recommended courses, ICOG and IAGE. You have to have few assisted cases under your mentor. You can work on animal modules and pelvic trainer in J&J facilities or in CIC, and you should be thorough with pelvic anatomy before you actually start working actually on the patient. A very similar study was done in 2014, where residents getting exposed to total laparoscopic hysterectomy, they pick up very fast when they actually come into practice. A proper OR setup, I will not go into details, but an ergonomically designed setup is must. You should have good anesthesia setup, separate screen for assistant, surgeon, and vaginal manipulator person, and you should have a good general anesthesia setup with multi-para monitor for medical legal ease also. And coming to the instrumentation, a basic HD camera system is must. There were times when standard definition systems were available, even on CCTV people have done, but now with decreasing cost of the system, a good HD system with a LED light source and a good recording system to improvise on your own surgical skills is very vital. A good energy source, not necessarily a very fancy or a expensive energy source, but a basic energy source which delivers very good calibrated bipolar energy is all what is required for most of the surgeries. And if you are able to manage ultrasonic or vessel sealers, it is going to add to the luxury. So standard trolley for a total laparoscopic hysterectomy, what normally I use is a pair of curved scissors, two good grasping forceps, one bipolar forceps, preferably a rotating bipolar, simple monopolar spatula or a harmonic for colpotomy, a good suction and lavage, two needle holders preferably, and if you are using extracorporeal knot tying, a good knot pusher. So now coming to the basic and standard steps after creating the pneumo insufflation. Yes, my personal choice for putting port is one umbilical if it is a normal size uterus or till 12 weeks. If it is larger than 12 weeks, you preferably go supraumbilical, or I prefer a Palmer's point. Then two lateral ports, and I prefer a midline port for my dissection and using the energy source. But a surgeon with less height, a lot of prefer a Palmer's or a lateral third port. So after putting the port and insufflation, you start the coagulating the cornual pedicles. Usually we start with round ligament. If at all ovaries are to be preserved, you dissect the ovarian ligament. Then the step of bladder dissection starts and skeletonization of the uterine artery. They are two simultaneous process. As seen in the surgical video, if you go fiber by fiber, the tissue identification with new camera system is usually very good. My personal choice is scissor and bipolar, especially in areas of bladder, but you can use ultrasonic scissor also in such situation. Continuously maintaining hemostasis is something very vital, especially when you are working in areas like this. And when you go fiber by fiber, ultimately it does not slow down your speed. Ultimately, you will complete the procedure little fast, efficiently, and without creating complications. Now in this step, I am working near the bladder pillar. So once you have dissected the peritoneum, it is vital to skeletonize the uterine vessels anteriorly by dissecting the bladder pillars and posteriorly by dissecting the broad ligament. This technique is especially important in cases of previous C-section where you may anticipate little amount of adhesion. Now when you are using only bipolar energy, it is always essential to coagulate the ascending branch, so that to avoid retrograde this thing with good ultrasonic this thing 7 vessel can be taken only with ultrasonic, but my personal choice is bipolar, because I always believe that ultrasonic is a good dissector and not a very good hemostatic instrument. Once you are through with your uterines, always dissect above the uterosacral and preferably preserve the uterosacral to facilitate the natural support of the vault. Now this step is to lateralize the uterine to create space for colpotomizer, and in all benign conditions it is always wise to go intrafacially in hysterectomy. Now same procedure is repeated on the other side, so I'll skip that. And once you have handled uterine on both the sides, further intrafacial dissection is carried out to facilitate the colpotomizer. Now here there are a lot of variations in opening the vaginal vault. We have had surgeons who do not use vaginal manipulator and just put a small pipe or a gauze and they completely dissect from above. My personal choice is Clemoferran manipulator. It has the advantage of rotation, where the area where you want to dissect can be made very prominent with this. And once the uterus is delivered, the dissected, it is delivered vaginally, and then is the turn for wall suturing. I personally prefer extracorporeal note, but you can use a barb suture also in this situation, or intracorporeal normal vicryl also. I do extracorporeal suturing from my midline trocar. So there are different ways of suturing the vault. What usually I do is I put 2 box stitches on both the angles, and if there is still space left in between, I suture it in between also. I've seen senior surgeons doing only the hemostatic part and leaving the vault open.
Sunday. Monday.
A delayed absorbable suture material should be used, so chances of vault dehiscence does not take place. Once you are through with suturing of the vault, check for integrity of all the vital organs, secure hemostasis, and as per recent studies, it is proved beyond doubt that in the cases where you want to preserve ovary, at least the fallopian tube should be removed. So chances of epithelial ovarian carcinoma of ovary is much less when you do this step, and you can simply do it within 2 or 3 minutes after completion of the procedure with a ultrasonic or a bipolar. And whenever you feel that functional ovaries are there and the pedicle is thin, it is always good idea to do ovariopexy in the same sitting to avoid ovarian torsion. So these are the standard steps of total laparoscopic hysterectomy. The basic difference between extrafacial and intrafacial hysterectomy is in an abdominal surgery, you always go very near to the uterine vasculature from above and you take larger chance. But in a typical intrafacial hysterectomy, you go little lateral from above, dissect properly, and then uterine artery is handled as a single unit. And when you see on the other part, this is where you start your dissection in the fascia between the cervix and the uterus. You dissect the fascia gradually, go inside, so the said neurovascular bundle in the fascia is completely preserved. You have extremely less chances of bladder and bowel dysfunction afterwards. And this is one equipment which can change and reduce the amount of time because of its special actions. This part stays inside the uterus. You can control the angle of anteversion from here. This is colpotomizer, which pushes the vaginal vault for proper cutting. The different level valves prevent the gas leakage, and this is to facilitate the rotation of the colpotomizer. So this is how it is introduced inside and manipulated in such a way so that you increase the distance. Apart from this, when you mobilize the uterus on the other side, either with myoma screw or manipulator, you actually increase the distance between the ureter and the uterine vessel, and so chances of injury to the ureter is reduced. You can see in this slide that when a proper manipulation of the uterus is done, this is where the ureter enters the ureteric tunnel and goes inside. And actually this is the site where you desiccate the uterine, and this is where the ureter is. So there is a safe 2 to 3 centimeters distance. Even after coagulation, there is a good distance. So even if there is a spill or a second time coagulation is required, you have safe distance. Now there are certain specific situations. The time will not permit me to go in detail about all the situations, but there are specific situations where you need little modification in the technique. Like in case of previous C-section, I'll quickly go through this video where you have to follow the lateral window technique. So between the uterine and the bladder, you identify the virgin area, and from there you try and dissect and reach the cervix. And then once you have reached the cervix, sharp dissection of the fibers using least energy. Only small bursts are taken, and always identify the tissue before cutting them. If at all in doubt, you can inflate the bladder, insert dye inside, and gradually do the dissection. Okay, so I'll quickly go about this. And once you start finding the glistening white surface, that is the end point of your dissection, and then you can very safely mobilize the bladder on this. Okay. Then there are situations where huge myomas, you encounter certain huge myomas, and in such situation, my personal preference is to put 2 11 mm trocar above, especially when you are using a 3D 0-degree telescope, and use a myoma screw from one of the ports. And as soon as you are through with your left side, change the telescope and myoma screw position and go ahead with this. Once you are through with your one side dissection, basically change to the other side. So initially put your telescope from here, carry out the dissection. This was a case of a huge myoma, 24-week size uterus. So initial dissection was carried out by putting telescope here and manipulating the uterus from with a 10 mm myoma screw from this port, and then gradually switching over to the other side in the same manner. I think the slide is hanging, so I'll switch to the next slide. So a few modifications depending on the situation is required. Same is true for endometriosis. When you encounter very dense endometriosis in posterior pouch of Douglas, it is always vital to remain in right plane of cleavage, dissect all the possible areas of endometriosis, correct the anatomy before you proceed with hello.
Hello, Sujal. Slides are not moving.
Audible?
You are audible. Slides are not moving.
Yeah, there's probably there is some problem with my
Laptop, no problem. You can conclude by you can tell the points
I
out.
think I
No
have
problem.
completed my yes, I have completed my talk. Basically, total laparoscopic hysterectomy it has emerged as a very safe technique. Only thing you need to do is you need to follow certain protocols and go step by step, irrespective of pathology or size of the uterus. You need to follow certain principles of this thing. Invest on good instrumentation and OR setup, and once you are through with this thing, you can very easily conclude these procedures without any complications. So I would request the audiovisual person to cut down my screen sharing if it is possible from your side, because
You can. I will tell
So
them.
you
I
can
will
stop,
tell.
sir.
He is not able to stop. Atulya called them. By the time you can share. You can share your screen, Atulya.
Sir.
Just see so that it will get shared.
Okay, now it is visible. I think I'll be able to
Okay.
stop my screen.
Okay. Thank you, Sujal.
Sorry for the technical trouble from
Yes.
probably.
Thank you, Dr. Sujal Munshi, for
Yes.
explaining everything in a very simplified way. Can we take some questions now?
Questions. Okay, questions will be taken after Jayagashan sir's talk together.
Okay. So maybe we can go into
share the next. Now, Sam sir, you can.
So it's my proud privilege to introduce Jayagashan sir. He's my mentor. When we were students, we are inspired by three great giants, that is Rajan sir, Jayagashan sir, and Paul sir. Sir is the Director and Chief Consultant Reproductive Medicine, KJ Hospital, Trivandrum. Sir has got more than 12 years experience in medical college and 23 years experience in private setup. More than 35 years of experience in treating subscribed subjects. Performed more than 14,500 endoscopy procedures. He's the principal investigator for 3 research projects. More than 5,150 cycles in ART. Has 7 publications to his credit. 36 publications in national journals. Winner of Akcog Tamban Award, Foxy Orion Award, treated more than 260, trained more than 260 trainees, involved into international trials, contributed chapters in 17 books, published 2 books, Practical Insights to Infertility Management, Insights to Infertility Management, second edition updates in infertility, and bioepic in Malayalam. Achievements: 8 publications in international journals, 36 publications in index journals, winner Akcog Tamban Award, Foxy Korean Award, and sir is the organizing chairperson of the famous Advanced International Conference for the past 21 years. Over to you, sir.
So thank you, Dr. Sam, for reading this. I'm just going to take you through hysteroscopy and infertility. Hope the screen is visible, Dr. Ashwath. Sam, you're able to see the screen, full slide sharing?
Yes, sir. We are able to see, sir.
Yeah. So first of all, I'd like to thank Dr. Ashwath for the kind invitation and Dr. SUBASH for the invitation. And I'm just going to take you through a relatively different topic.
Make it full screen, sir. Make it full screen. Jayagashan sir, full screen.
Yeah. Full screen. You're not seeing the full screen now?
No. Just put in the slideshow. Then it will be full screen.
Hope it's clear now.
No. Slideshow, sir. Click the slideshow once more. Sir, more in the click on the slideshow more.
Okay.
Click to view, click, sir. More point slideshow, click, sir.
Yeah.
More point slideshow, click here, sir. Okay, that's it. Sir, done.
Yeah, I'm taking you through a relatively different aspect. I'm not going through the intracavitary lesions diagnosed by histoscopy, which all of you are quite aware. and I'm taking you through recognizing endometrial pathologies by hysteroscopy. Ambulatory operative hysteroscopy is based on the principle that you see and treat. Gone are the days where you do a blind DNC and you miss about 1/3 of the lesions and you find you cut a sorry figure in the front of the patient. So a lot of technical innovation has occurred for ambulatory or the office hysteroscopy. We use a smaller caliber sheath, continuous flow devices, and a working channel which facilitates insertion of mechanical instruments as well as bipolar or unipolar electrodes also, which helps you to perform the procedure. It can be done without analgesics or anesthesia. That is what the Europeans do. But in our setup, usually we give analgesics or a short anesthesia. The basic principles why analgesia and anesthesia is not needed: using small caliber instruments, dilatation of the cervix is not required, putting the speculum is not required, catching the cervix is not required, and you gain entry into the cavity based on the principle that sensory innervation is invested in the myometrium and it does not reach the endometrium. So you can perform surgery on the endometrium without causing any pain in majority of the patients. But our setup, we find that we use more of a short anesthesia for this procedure. The use of bipolar technology has been an important revolution in hysteroscopy because we use 5 French electrodes, we use normal saline when bipolar is used, and we can reduce the complications associated with the monopolar as well as use of glycine. And suppose you're doing a office hysteroscopy, we do a vaginoscopic approach where you don't put the speculum and the Alice and you balloon out the vagina by closing the introitus at the outside with a mop and gradually gain entry into the cavity. So whenever you see that the patient is not unconscious, you have to minimize the intracavity distension by keeping the pressure around about 30 to 40. Otherwise, we may use 100 to 120. And use of saline certainly has increased the patient compliance, but the flow rate has to be around 200 ml per minute and the suction pressure around 0.25 bars. The scopes has really revolutionized with arrival of 2.9 mm scope with 30 degrees and a sheath 2 mm outer diameter, 4 mm, and 2 sheets we have, one for the irrigation and one for the suction. And you should have an electrosurgical generator. Commonly we use Autocon, and we find that it's a dedicated miniaturized second generation, and it's quite good for laparoscopy as well as the hysteroscopic work. So I just get you through office hysteroscopy. Even though this patient, we are doing it under a short GA. This is a beautiful picture of the ballooning of the vagina and detecting any lesions in the posterior fornix. The squamous columnar junction is seen, and you can see the external os, little bit of mucus and the betadine over there, the columnar epithelium. The first aim is to find the passage right into the cavity. For that, you have to walk through the cave. I usually tell my juniors or colleagues, you have to see the cave and you have to get into the cave. And once you gain entry, that is the end of the cave. And these are the landmarks, the 2 osteo on either sides, anterior wall, posterior wall. You can have a panoramic view of the cavity. And also you have a look from the internal os also. So almost 80 to 90% of the cases, you can do the office hysteroscopy without dilatation. Less than 10% of the cases, you may require a dilatation of the cervix. Now I come to the endometrial pathologies diagnosed and treated. Endometrial polyps are usually asymptomatic. It is diagnosed by routine scan, and polyps less than 5 millimeters can be left behind. But over a period of time, around 6 months, the patient doesn't conceive and the polyps still are remaining. It's around 5 millimeter to 10 millimeter. it requires intervention. So this is a picture of the polyps. It is a focal hyperechoic, well-defined thickening of the lesion, represented by a 3D scan. If you have a 3D scan, much more information you gain by doing a 3D scan also. And sometimes you come across multiple polyps in the anterior wall and posterior wall. So, and sometimes it becomes recurrent also. So the etiology of the polyps, you find that there are specific genetic and family hereditary chromosomes. Mainly the chromosomes 6 and 20 are involved in the formation of the polyps. There are inflammatory factors playing, local production of interleukins, and there are endocrine factors like hyperestrogenism, sometimes seen commonly with polycystic ovarian disease, and iatrogenic factors, especially when the patient is on tamoxifen therapy, and it causes endometrial hyperplasia and polyp formation. So these are the etipathology of the polyps. And hysteroscopically, you should look into the number of polyps, the dimensions of the polyps. Normally, we use a 5 French alligator forceps with a maximum spread of 6 millimeter. We have to find the location to the tubal ostia, whether it's in the anterior wall, posterior wall, or the lateral walls. Consistency also soft or hard, more of a feel, and whether it is sessile or pedungulated. These are the features you look for a polyp. And especially when you look at the polyp, when you put the scope inside, you can see a polyp in the posterior wall. Always look at a relationship of the tubal ostia. And here the polyps are in the posterior wall. And there are multiple polyps also in the posterior wall. It could be a polypoidal endometrium. And here there is another polyp in the anterior wall also. So location is important. And you take an alligator forceps or a grasper, go to the base, push into the fundus, and try to take the polyp out. So that is the basis of doing a polypectomy. And sometimes it is multiple, and sometimes it recurs also. And all these polyps are subjected to histopathological examination. So less than 5 millimeter polyps are removed with 5 French and go to the base, push towards the fundus, and many occasions you can detach the polyps from the base. But larger than 5 mm, this technique may not be useful in all cases. It has to be removed en bloc. For that, you can use the bipolar needle electrode pass through the operating channel, and you can go to the base and section and remove it, and then section it into smaller fragments and extract with the grasping instruments. So you can use a resectoscope when there are larger polyps, and which is reluctant to ambulatory procedure, because there's a number of polyps and the size of the polyps increases. You have to have serial slicing of the polyps, and sometimes these polyps have a broad base, so you have to resect the base of the sessile polyp. And so you can use a combination of a mechanical instrument like grasper or a needle electrode passed through the 5 French of a Bertolucci hysteroscope and complete the procedure. Another condition which we have to remember in infertility is chronic endometritis, where you find the endometrium is not so healthy. That looks like scarring along with some hyperemic areas. And any suspicion of this endometrium, we have to subject them for histopathological examination. Definitely the diagnosis is histopathology, but the suspicion is look at the scarring, look at this annular ring prior to the entry. There is something which suggests that it's not normal. So whenever it is abnormal, you subject them for the histopathology and you diagnose it as a case of chronic endometritis. Occasionally, we come across TB endometritis. Patient may have a scanty flow, and you find amenorrhea sometimes, almost devoid of the endometrium, and you find white patches with what you call as a shaggy appearance of and some grooves. And you can do a targeted biopsy by hysteroscopic evaluation of the endometrium. A blind biopsy may miss the lesion, because in this case, you find that the tuberculous endometritis is on the anterior wall of the uterus. So never a blind biopsy, always a targeted biopsy, and subject them for histopathology, as well as we send it for a gene expert, a PCR test, which you can get within 2 to 6 hours, or you can culture them in a mycobacterium growth indicated tube for 7 days. And once the result comes, it is TB positive, then you have to give them antituberculous treatment for 6 months, along with a consultation of a pulmonologist. And sometimes you find that these type of small micropolyps, which are suggestive of endometritis. So micropolyps also, if you see, you subject them for histopathology. And at histology, you find that it is a sign of you find there is accumulation of inflammatory cells, plasma cells, eosinophilic granulocytes, and along with the normal stromal cells. And staining is also good enough to, immunohistochemistry is also good enough to diagnose chronic endometritis. Now I move on to the last chapter of my talk. We come across endometrial hyperplasia, where you find abnormal excessive glandular proliferation. And the 4 main categories, the old classification was simple endometrial hyperplasia, complex endometrial hyperplasia, with and without atypia. But WHO's classification 2015 classifies endometrial hyperplasia as 2 categories alone: hyperplasia without atypia and atypical hyperplasia. There are only 2 categories: without atypia and atypia with atypia, that is atypical hyperplasia. And this is a revised classification. Diagnosis definitely by ultrasound, where you see the thickened endometrium, 10, 12, 15, 18, and 20 millimeters. Hysteroscopic predictors of endometrial hyperplasia will be polypoidal or papillary thickening, which could be focal or diffuse. The vascular pattern is abnormal, and the presence of glandular cyst. And you see glandular outlets also, which are thickening of the irregular gland and dilatation of the glands also. So it's more of a histological diagnosis. But endometrial hyperplasia, you go for the targeted biopsy and go and take biopsies from the endometrium and the hyperplastic areas. The endometrium is in thick areas, and subject them for histopathology, and you get the diagnosis of hyperplasia without atypia. And what do you do without atypia? We give progestogens, norethindrone or norethistrone, 30 milligram per day for 6 months. And we reassess after 3 months with an ultrasound. And after 6 months, you can do a pipple sampling also and find out whether there is a regression of the endometrial hyperplasia. Mind you, these are patients coming with infertility. And with atypia, endometrial hyperplasia with atypia, the standard treatment is total hysterectomy with BSO and a staging laparotomy. And but we have patients coming to us who want to preserve their fertility. So even if it is having atypia, endometrial hyperplasia with atypia, to conserve or preserve the fertility, we have to give them anti-estrogens and anti-proliferative effects. And the 2 drugs which we use are progestogens and GnRH agonists, which has got an efficacy of 75%. So literature review, more than 2,500 patients reported that atypical endometrial hyperplasia, that is 37% of the women will have endometrial carcinoma and subsequent biopsy or hysterectomy. So atypia, definitely a high incidence of malignancy is associated. So you have to be very careful. So the question asked common is whether you want a pipple sampling or a hysteroscopic sampling. Diagnostic hysteroscopy should be considered to obtain an endometrial sample, especially when the outpatient. Normally we do the pipple sampling, but sometimes it is difficult. The pipple doesn't go into the cavity and outpatient sample fails. So direct visualization and biopsy of the uterine cavity should be undertaken when endometrial hyperplasia is diagnosed, when pipple sampling has failed, or when you diagnose discrete lesion, focal lesion, or a polyp. So these are the indications for going in for a hysteroscopic. So the first line of treatment, of course, I have told regarding hyperplasia without atypia, is to put a LNG device, or If the patient is not in favor of that, you go for progestogens, which helps to regress the endometrial hyperplasia. So LNG devices, the levonorgestrel, IUDs, Marina should be the first medical treatment according to the NICE guidelines. But often we find that our patients don't agree to that. They would like to have oral progestogens. But compared to that, it has a higher disease regression, more favorable bleeding profile. So LNG should be the first line of medical line. If the patient doesn't want LNG IUDs, you can go for oral progestogens, and that should be how to give oral progestogens. We have to give medroxyprogesterone 10 to 20 milligram per day, or norethisterone 15 milligram per day. Those who decline LNG IUS. And most important thing, never give cyclical progestogens. You don't allow the bleeding to occur, because if bleeding occurs, it is less effective in inducing regression of the endometrial hyperplasia. So continuously you have to give it for 3 months or 6 months. So how about endometrial surveillance? Endometrial surveillance should be a minimum of 6 monthly, but 2 consecutive 6 monthly negative biopsies should be obtained prior to discharge. That is without atypia. With atypia, hysterectomy is indicated in women not wanting to preserve the fertility, and progression to atypical hyperplasia occurs during follow-up, or no histological regression of the hyperplasia despite 12 months of treatment. So endometrial hyperplasia with atypia, no regression occurs. You think about hysterectomy, ask them to complete the family immediately. And meta-analysis has shown that regression rates for atypical hyperplasia is around 85%, and the relapse rate is 26%, and the live birth rate is 3%. And those patients who wish to preserve the fertility who are not suitable for surgery should be counseled regarding the risk of malignancy. So the first line is LNG IUS. Not in favor, you have to give the second alternative, oral progestogens. And once reversion has occurred, they have to go for assisted reproduction, because this is a small period which they have to complete the family. And prior to assisted reproduction, regression of the endometrial hyperplasia should be achieved, but as it is associated with higher implantation rates. So this is in short regarding an atypical hyperplasia. We have to review them every 3 months. And without atypia, we have to review them once in 6 months. So take home messages: gone are the era of blind DNC. The present era should be see and treat. Ambulatory hysteroscopy plays an important role, but in our setup still it's not ambulatory, it is in the theater. Hysteroscopic procedures play an important role and in reproductive age group and infertility, as well as postmenopausal age group, and you have to take it with due consideration. And office hysteroscopy is an important tool to reckon with. So thank you very much for the patient hearing, and hope to see you all for a hybrid advances into November 2nd week. Thank you very much, ASWATH, for the kind invitation.
Thank you. Dr. Usha and Sam, sir, please take some few questions which I have sent to you from the audience. Just continue discussion for next 5 to 10 minutes.
There's a question to Jayakrishnan, sir. Sir, how will you negotiate a stenosis in internal loss during hysteroscopy?
Commonly, whenever the stenosis is there, we usually put an ultrasound over the abdomen and try to dilate it, because we are not kept a cytotech or misoprostol. So normally we put an abdominal scan and try to put the dilate, and sometimes it is quite difficult, and you enter into but if the patient, you have a history already of difficult dilatation, I would recommend a misoprostol 200 to 400 microgram 2 hours prior to the procedure.
Sir, can you please stop sharing the screen, sir?
Screen correct.
Do you? There's a query, another query. Do you use a scissors to make way for the scope in a stenotic cervix? In an internal osseous very stenotic, do you use scissors to cut open the scar, whatever is there?
No, I think the incidence is very, very less. We don't have to cut open it. So most of the lesions, I think almost majority of the, unless you have created false passages, you are able to gain entry. And I think dilatation and occasionally we find that some annular ring in the near the cervix, maybe one case or so which I had to use a scissors to cut. Otherwise, most of them it's an ultrasound guided or dilatation under ultrasound guidance.
Anybody would like to comment about? Okay, sir. There's another query. Role of histoscoping in suspected malignant lesion in the endometrium.
Yeah, only the drawback one has to keep in mind is to reduce the intrauterine pressure. There is likelihood of you pushing the endometriotic carcinoma through the tube into the peritoneal cavity. And there is only lesion, but I think it's a small problem, but still for diagnosis, sometimes especially a focal lesion or a polyp which shows atypia, missing it by routine DNC is definitely looking, see and treat is a much added advantage. So I don't consider it as a big disadvantage, but definitely the pros are in favor of hysteroscopic directed biopsy.
Sujal, some tips for TLH in endometriosis. TLH in endometriosis. Steps to be taken. 1, 2, 3, 4.
There are two ways of approaching this thing. In TLH, first identify the pathway of ureter, what you are worried about, and second is try and dissect in the area you want to be lesion free. So initially there is something known as reverse technique. You try and identify, go in the lesion, separate rectum from the uterus, get away with the uterus and complete the laparoscopic hysterectomy. And after that, whatever lesion is there, you always will have a mobility to work on the rectum. And if it is a frozen pelvis, you can lift this thing and remove it. Preoperatively, if the lesion is causing stricture or something and something is to be done on the bowel, that can also be simultaneously done. But only thing is you have to plan, and a good clinical examination would help you plan the procedure very effectively. But always identify all the structures by going retroperitoneally and then only proceed in cases of difficult endometriosis.
Dr. Sujal?
Yes.
Something about uterine manipulation. You told that manipulator and another, some people use myoma screw. So is there any difference?
That is individual choice. What advantage
you get more traction?
Yes, with
screw.
The manipulator, one of the port remains completely free. So you have all three working ports with you. When you use a myoma screw from above, the one port is utilized in myoma screw, and then you will have only two working ports. Second discomfort which I very commonly find is when you take out the myoma and replace it at the other place, there is some amount of oozing continuously going on. So that is not there with this thing. Otherwise, manipulation with both the instrument is very good. I find it personally very interesting when there is a limitation of space and you want extra retraction. Apart from manipulation, myoma screw would help. But for manipulator, the colpotomizer increases the distance between your uterine artery and the ureter and makes it very safe. So chances of thermal injury to the ureter decreases, and also it helps in bladder mobilization sometimes to get a good plane of cleavage. So, but then again, as I've said, it is a personal preference for the surgeon. Both have their own advantages and disadvantages.
So it's individual choice whether you want to use a manipulator or a myoma screw. And at each step of hysterectomy, how do you prevent ureteric injury?
So first is, now there are a lot of surgeons who completely open the retroperitoneum. I personally don't feel for each and every benign case you need to do a ureterolysis, but at least you should be aware of the pathway of the ureters. Before starting the procedure, always confirm the peristalsis of the ureter and proper mobilization of bladder. Giving angulation at the time of uterine, always retract the uterus on the other side with manipulator or myoma screw to increase the distance, and always remain intrafacially, especially in case benign surgeries. These are the three essential steps to reduce the injury to ureter.
As we are running short of time, people are waiting for the rest of the questions will be answered in the chat box by the so many queries are there coming from the participants. So we will go for the Adulya. Thank you, Sujal, and thank you, Jayagashan sir, and especially thank you, Sam sir and Dr. Usha for excellent moderation and being there for the program. So thank you all the speakers.
Thank you so much.
Both the speakers and both the chairperson. Thank you so much. Adulya, take over.
Thank you, sir. Now we'll move on to the second session. Introducing the chairpersons, Dr. Hari Prasad. I'll share my slides. Dr. Hari Prasad and Dr. Ajita. So Dr. Ajita is having difficulty getting in from her laptop. She's not able to get in, sir. So I'll introduce Dr. Hari Prasad. He's consultant VGYN, working as consultant in the Lood Hospital, Taliparamba, since 1993, and he's now working as a chief consultant in Fetal Medicine Center, Kannur. And he is a regional coordinator and assessor for CRMD Kerala. And he has presented papers in AKCOG, AICOG, and he's got special interest in fetal medicine and high-risk obstetric endoscopy and infertility. Dr. Ajita, she's a consultant at Aster MIMS, Calicut, Aster Al Rafa, Muscat, Mithera Hospital, Calicut, Baby Memorial, and Star Care Hospital, Calicut. She is a president of Calicut Menopause Society, and she is awarded the Best President Award, IMA, and she has nice endoscopic workshops in Kerala, and she is field of interest for laparoscopy and robotic surgery. Dr. Hari Prasad, can you please introduce speaker for this session, Dr. Hafiz Rahman?
Good evening, everybody. This can we ask the Medcon guys to just let Dr. Ajita in? She's waiting for the past 5 minutes. Anybody from Medcon?
So they are saying that her laptop has some problem, and we have asked her to try to log in from her phone.
No, she has just done now. She has just done once again. She just tried a couple of times now.
So she cannot get in.
No, still. She's still waiting. She's just waiting for us.
Okay.
Hello.
By the time, Adulya, please share the CV of Officer if it is there. No, Hari Prasad sir, you can introduce Officer and start the program by the time. Hari Prasad sir, you can introduce Officer.
Good evening, everybody. This is a great pleasure to introduce Dr. Hafiz Rahman. He is my classmate, that is for MBBS, same batch. We studied together, and I learned laparoscopic procedures from Dr. Hafiz and also Dr. Paul sir. Dr. Hafiz is internationally famous endoscopic surgeon. He has a setup in all over India and abroad. He taught a lot of Indians in the endoscopic procedures, and everybody know what Hafiz is. So Hafiz.
Yeah. Can I share the screen?
Yes, sir. You try to share.
So you are seeing the slide?
Yes. Everything. Very well, sir.
It was nice to have been introduced by Hari Prasad. Hari Prasad was started as my body mate because so both of us were body mates, then we were roommates, then we were karate mates. So it was nice to be introduced by such a person who is so close to my heart. Now let us get into this topic of, basically I'll be talking on prolapse, not really on lap sacrocolpopexy alone. So first I would like to introduce the concept in which we are dealing prolapse, which is actually completely different from the concept which we had before. During our postgraduate days, we always used to say that this is due to multiple birth trauma or multiple pelvic trauma that prolapse occurs. The collagen will get loosened and collagen will get destroyed. That is why the prolapse will occur. But it's not really only due to birth trauma. We all today know that it's a defect of the collagen basically. It's a manufacturing defect of the collagen which leads to these kind of problems. So now I think this part all of us know about till now, that it's a manufacturing defect of the collagen. And because of this manufacturing defect of collagen, we know that there has to be some kind of a replacement for this collagen. So there is, I don't feel that there is any role for again and again repairing this collagen, because one basic reason why I say that is because these spaces in the pelvis, we can dissect into these spaces only once. The second time you go into these spaces, you find that it's extremely difficult. So if at all you are dealing with a prolapse of a patient, do it thoroughly in the first instance so that you will get into the correct plane and complications will be very less. Whenever the mesh is kept in an area where it was dissected before, and now you are dissecting it again, the chances of erosion is much more, basically because you will not get into the correct plane. Now, one of the most important thing in this procedures is getting into the correct plane, and we will see what is the correct plane. To understand which is the correct plane, one thing which we have to understand is that each and every viscera is covered by a fascia. As you can see here, you can see the rectum is covered by a fascia, right? And you can see the sacrum here. The sacrum is also covered by a fascia. And there is a plane between the sacrum and the rectum. See here also between the cervix or between the vagina and the rectum, there is a plane. Between the bladder and the cervix also, there is a plane. See, this tissue which covers each and every viscera, this darkened tissue which you see here is not plain. Most of the time, problem occurs when you dissect into the darkened tissue. The problems of this area, see, the advantage of dissecting in this area when you do it properly is that this area does not have much of vessels. This area does not have much of nerves. See, when we were all doing with this procedure, or when we started with this procedure, dissecting right up to the levator, one of the big complications we had is basically the constipation or dysfunction of the rectum. So we saw that it is basically due to the nerve injury in this dissection. So we started understanding this anatomy much better, and we started dissecting in the correct plane where there are no nerves. I'll show you the dissection where there are no nerves. And we saw that there is a drastic difference in the rectal dysfunction after these kind of procedures. Initially, we thought that it is because of the mesh obstructing the rectum, but it's never the mesh obstructing the rectum. The mesh will never obstruct the rectum, but it is basically due to the injury to the nerves which are supplying the rectum. Now, you know that there are different methods. There are different methods, whether it's posterior fixation, anterior fixation, and all those procedures have come. The problem is the surgeons decide the surgeons will make procedures according to their skill and according to the skill, and that's where the entire problem comes. There are a lot of anterior fixation procedures. We have done it a lot, and today we have left it completely. All these anterior fixation procedures, I've left it completely. If you see this picture here, if you see the picture here, you can see that the vagina is an antro-posteriorly directed. It's not postero-anteriorly directed. It's not directed like this. The vagina in the normal patient is an antro-posteriorly directed because of sexual contact, and it is always directed towards the sacral promontory. So this fixation, if it has to be in the normal position, it has to be fixed like this onto the sacral promontory, which is the this diameter. It has to be fixed. Imagine the same vagina getting fixed here. That is a pectopexy, which we usually do. If getting it fixed here, you can see the length of vagina reduces drastically. And you can see that it will go and compress the bladder, which is actually a bigger problem than compressing the rectum. Here, actually, it doesn't compress the rectum because rectum always comes from the side when it goes above near the sacral promontory. It's actually a free area, and the rectum comes from the side, from the sigmoid, and it doesn't usually get compressed. So you need to understand this concept before you go ahead for this kind of surgery. That is why we have left anterior fixations completely. And anterior pelvic relaxation fixations are basically only and only for bladder fixation. It is not for the vaginal fixation. It is never for the fixation of the uterus as far as I am concerned. Now, if you look at the nerves here, you can see the autonomous nervous system here very clearly. You can see that the nerves come initially on top of the sacral promontory. You know, previously when we used to do this surgery, we used to make the sacral promontory completely naked to see the bone, and we were quite happy. But understand that you have destroyed all the nerves there once you make that sacral promontory completely naked. And if you are seeing the bone, understand that you have destroyed all these superior hypogastric plexus, which is not a mixed, it's a non-mixed plexus. And if you dissect it like this here in an abnormal plane, you will find that you are going to destroy all these nerves here if you dissect it in an abnormal plane. So this normal and the correct plane, not normal or abnormal, actually the correct plane of dissection is extremely important in these patients. Now, let me talk to you something about the mesh also. Initially, when we were keeping the mesh, we always felt that, what was taught to us, the mesh will produce fibrosis, the fibroblast will grow into the mesh, and it will create good support. It's absolutely a wrong method of doing it. Yes, fibroblasts were growing into the mesh because the type of mesh which we put were completely different, and the plane in which you put the mesh is completely different. You put the mesh in the correct plane, which I am telling, you will find that the rectum will move on top of the mesh. If you see on ultrasound post-operatively, the movement of the viscera on top of the mesh post-operatively will ensure that the mesh will not erode into the rectum or the vagina. This is a very, very important concept and the fibroblast growth will be much lesser in this plane. Because we have seen cases where we had to remove the mesh due to other reasons. When you put the mesh in the correct plane, you find that the fibroblast growth is much lesser, and you will find that it is much more easier to remove the mesh from that particular plane. Now, if you see the surgery here, I'll just show you the plane. This is for a prolapsed uterus where we are fixing in a little different method of procedure. We call it as the Rahman's method. And here you can see we start the dissection from the sacral promontory area. You can see both the things, both the peritoneum is kept taut upwards so that you will ideally get into the correct plane. So this is very important. Can you see that? We are cutting. You can see there is a plane there is a fascia on top of the sacrum. You can see there is a fascia. This is the rectal fascia actually. So you cut into the rectal fascia. This fascia here, this is the rectal fascia. So you cut below the rectal fascia. Do not go into this plane. This plane is where you will go into the rectal fascia, and you will find that it's a little more vascular plane. Now, if you go in this plane, can you see here? If you see here, if you watch here very carefully, can you see that the sacral promontory is not naked? You can see the entire group of vessels on the sacral promontory. You can see the entire group of nerves on the sacral promontory, which is completely untouched. The problem is if you coagulate all these nerves and try to dissect into the sacral promontory, you start having the problem. You can see that this area this plane will not have any nerves. Even if you go laterally also, it doesn't carry much of nerves. We need to go correctly in this plane. Very, very important concept of prolapse dissection. My complications and problems have reduced drastically after I started adopting this plane. You can see that you can right up to the piriformis muscle. You can see how avascular it is. Can you see this nerves here? Very clearly. Now you can go laterally and you can dissect into the You can dissect down into the pelvis. You have to go medial to utrocecal when you dissect down. See, that's the utrocecal, and you can see here I am not dissecting too much down because the nerves from here, they cross the utrocecal here laterally and go upwards. And you can see that you are dissecting in between the two layers of the tenovillous fascia, between the rectum and the vagina. You will see that we clearly preserve the fascia over the vagina, and we will clearly preserve the fascia over the rectum. This correct plane is extremely important here also. You can see that we are opening into the correct plane. Can you see that? And this plane is usually achieved by the correct traction. You can see that fascia over the rectum. See, this is the fascia over the rectum, and this has to be preserved properly when you dissect. Now, another thing is we dissect right up to the levator. You can see the levator here. You can see it is dissected right up to the levator. You can see the fat and fascia is preserved on the rectum. The levator is nicely resected. In any case of prolapse, do not do an apical correction alone. This is a very wrong concept. I've seen people just hanging the mesh onto the cervix like a sling, and the mesh is not kept flat. See, all these mesh surgeries, mesh is not a sling. Mesh is a replacement of the collagen, and collagen is all over. Collagen doesn't come as a ligament. Thickening of the collagens are only coming as ligament. So mesh has to be flat here. And this mesh, you can see that it is kept loose. I'm not pulling the mesh tightly upwards. You can see that I've kept the mesh loose so that the rectal movement, everything is preserved. And this mesh used is a titanomized mesh. Do not use a mesh which will produce adhesion. This mesh, titanomized mesh, will not get adherent to the tissues. It is used for incisional hernia, intraperitoneal. It's basically an intraperitoneal mesh or a composite kind of mesh which will not get adherent. Previously, we used to have this physio mesh, but now we don't get physio mesh. So this is a titanomized mesh which can be used. This is why the rectum will never get adherent onto this mesh, and it will move very smoothly. And here you can see how we will fix the uterus. You need to take, see, you take an anterior suture onto the uterus, then you take it like an encirclage, because if you fix only the posterior cervix, there is high chance that the mesh can cut through the sutures can cut the cervix, and the recurrence is always there. So you fix it and do not overcorrect the uterus. The overcorrection of the uterus, I have always seen that there is a lot of chance of getting stress incontinence whenever you do an overcorrection. So never overcorrect the uterus in good enthusiasm. Now you take it through the mesh. You can see the mesh is very relaxed, but still when you see, you will that when you pull it, the mesh tightens from the sacral promontory. Below the attachment of the uterus, the mesh will be relaxed, but above the attachment of the uterus, you will find that the mesh tightens. You can see that you can take it around the cervix very easily here, and then tie it. You will find that the uterus is held upwards very nicely. And this, I feel, will be the most ideal method if you want to preserve the uterus in these kind of patients, because this one, we have not seen any recurrence so far. And this I would prefer to be the best method, because I've done a lot of anterior. You can see how the uterus is upwards. You can see the rectocele is gone. Cystocele, little cystocele, I prefer to keep, because to avoid stress incontinence, this is very important to keep little cystocele. Now, we have tried all methods. We have tried the anterior fixation. We have tried different types of posterior fixation. I've tried the sling surgeries for uterine fixation. But today, I am of the opinion that this will be the most ideal method for fixing the uterus. And even if you want to fix the uterus, if you want to fix the vault also, it is the same way which is done. But understand the vault has to be fixed as an anteroposteriorly approximated. Never try to fix one apex of the vault. Here I just kept the cervix, and we are fixing a cervix after subtotal hysterectomy. You can see that the mesh is kept flat. The mesh is never crumbled, and it is kept flat like the fascia, which is very, very important. And this is how you fix the cervix. And then you will, then we will usually close the peritoneum nicely so that the mesh is never getting exposed. And this is how we fix the vault. When the cervix is not there, can you see that the vault is not fixed like a conical fashion? The vault is fixed flattened. The vagina is normally anteroposteriorly approximated. So you have to keep the vagina anteroposteriorly approximated when you fix it. You can see that the flattening of the top of the vagina is very, very important. And you can see the mesh throughout. It's not like a sling which is coming. And this works much, much better this has worked much better for me. And this I feel would be the most ideal method rather than doing a point apical fixation. You can see that it's a flattened vagina which is there. Rather than doing a point apical fixation or even changing the complete thing, and rather than doing a anterior pectopexy, this would be the most ideal method. If there is a bladder involvement, you can decide whether you have to do an anterior bladder fixation or you have to do a posterior bladder fixation. I don't have enough time to show you anterior bladder fixation. Anterior bladder fixation is basically paravaginal repair. When we put the mesh posterior to the bladder, we usually call it as a posterior bladder fixation, where the mesh is kept between the bladder and the cervix. In this case, what you have to be doing is basically you need to dissect right up to I am finishing. Right up and right up to the urethra, so that some amount of stress incontinence can be fixed when you do the anterior fixation. So thank you so much for your patient listening.
Thank you, sir. Next. Yeah. Hello.
Hello.
Sir.
Adulia, you can introduce next.
Dr. P.G. Paul. He's a chairman of Paul's Hospital.
I call Ajita madam to introduce. Ajita madam to introduce Paul, sir. Ajita madam is there. Yes, madam is there. Madam is there.
Yes. Yes.
Madam, you are audible. Yes, madam. You can talk. Introduce Paul, sir.
Yes. It's always a pleasure to see Sir Paul, sir, and to see him operate. And my pleasure to introduce a person whom I have known for more than 20 years. So everybody who meets Paul, sir, he is a friend, a very calm and quiet person, and a very skilled surgeon. Peter Paul, sir, is the chairman of Paul's Hospital, and he is a board member of ISGE and an elected member of ASRM since 1997. Sir has 2 books to his credit, and he has authored about 31 chapters in various books. He has 40 papers in international journals, and whenever anybody says Paul, sir, we always think of him as a person who has trained a lot of gynecologists in laparoscopy. And from his biodata, I found out that he has trained more than 1,800 gynecologists, and that's a great teacher, sir. And sir has also got the Lifetime Endoscopy Empowerment Award, and he is also the winner of the Distinguished Alumni Award. But for us all, Paul, sir, is a great laparoscopic surgeon who will always be remembered with love and affection.
Thank you, Ajita, for the kind introduction. I know Ajita for many, many years, and she is the first woman star of endoscopic surgery in the northern Kerala. Can I share my screen?
Yes, sir. You share.
Ashwata asked me to speak on endometrioma. So, can you see my screen?
Yes.
Yes, yes. Tips and tricks.
So he asked me to share my surgical experience in treating endometrioma. I was wondering why endometrioma is different from an ovarian cyst, because ovarian cyst is one of the simplest laparoscopic surgery all of us started with. The main difference is all endometriomas, or 99% of endometriomas, are extra ovarian. It starts as a small implant on the surface of the ovary, and then it grows into a cyst. So what you see as a cyst is not actually a true cyst. It is actually the pseudocyst formed on the surface of the ovarian cortex. Second difference is endometrioma is almost always associated with adhesions of different grade. Sometimes it may be superficial, and majority of the situation you will find deep infiltrating endometriosis also. And apart from treating the endometrioma, there may be many implants all over the uterus, pelvis, and you have to treat those along with the treatment of endometrioma. And nowadays, the main concern is whether we remove a lot of ovarian tissue, because being an extra ovarian mass, whenever you peel off, majority of the time you peel off the cortex and the ovarian tissue, which compromise the ovarian reserve of the patient, which is very important for most of the patients who are actually infertile. Again, the next concern is many a time you find they all come back with a recurrence in a short time, or some come after many years, but definitely there is a high chance of recurrence. So you have to consider all this when you treat an endometrioma. And all of us know that majority of the endometriosis will have, almost 50% will have an endometrioma, and around 30% of them will have an endometrioma bilaterally. This is the classical appearance of the ground glass echogenicity. A good transvaginal ultrasound, preferably done by the surgeon himself, make a lot of difference, because most of the recurrence do occurs because you miss small endometrioma loculi, and they all grow later, not the one you actually enucleated. And all of us know that surgical resection is the most important, most common procedure we all form. And we must always consider the dual blood supply from the infundibulopelvic ligament as well as from the ovarian side. So whenever you operate on this side, there is more bleeding and you need to coagulate. So you have to avoid deep dissection at this point, as well as the hilum, where you find the anastomotic vessels. And many a time, I will come to that later, the ovary is stuck on the pelvic side wall over the ureter, causing hydroureter and hydronephrosis. This is a typical case. I am just showing you, you might have seen all this. This is comparatively straightforward endometrioma. You can see bigger endometrioma on the right side and a smaller, and mostly unilocular. Majority of the endometriomas, you don't have to actually decompress. When you lift it up, the adhesion area where the endometrioma drains, and it's a matter of just lifting up and releasing from the pelvic side wall. I try to keep the peritoneum, so if you go from a normal side to from laterally and then start remaining close to the peritoneum, you will find the peritoneum can be preserved. Many of you might have observed that you find the ovary, although there is an endometrioma, looks very, very small. This is mainly because the ovary is stuck in the pelvic side wall, the ovarian fossa. So you have to really lift up the ovary from the ovarian fossa. So sometimes here you can, on the left side, you can find actually the ovarian tissue was looking very small. Then I try to identify the cleavage, and a suction irrigation comes very handy at this point, because you can irrigate rather than, you can actually inject vasopressin on the uterus before doing the adhesive lysis, apart from the vasopressin we are going to use. The actual enucleation of the step of endometrioma is the last step we do. So before that, you excise all these endometrial implants. many a time you find not only the implants, the associated inflammatory. You know that endometriosis is an inflammatory condition. It's not an infection, it's an inflammatory condition. So you'll find a lot of fleshy blebs and adhesions which need to be excised. And if they are very superficial, you can superficially coagulate. You can see that I don't actually use too much coagulation. My instrument is moving and washing off the blood to have a clean coagulation. And now we are coming to the right ovary. And before doing the actual enucleation, there may be many implants on the surface apart from the cyst, which has to be excised or coagulated. You can find that I'm injecting the vasopressin. Normally it is 20 units into 200 ml, and you inject more close to the ovarian ligament, where actually when you do the enucleation, there will not be a cleavage, and probably you will damage the ovarian ligament and blood supply. Here you can see whenever, even if you inject the vasopressin in a deeper plane, you don't have to enucleate in that plane. The injection of vasopressin is to get a space between the pseudocyst and the ovarian tissue. So you remain always close to the cyst, and you can see that when I come to the ovarian ligament, I have already injected the vasopressin. The next step is actually, there may be many implants. You can see many times the chance of recurrence is high if you retain these implants. So a meticulous inspection of the edges and a fine trimming, very little ovarian tissue is being lost. And now you look for any hemostasis. Any active bleeders are coagulated. In this case, you can see that I did not. And you find how I reconstructed the ovary with a bowel grasper. Here, if you find on the left side, actually the endometrioma is small and there is no clear layer. So actually injecting the vasopressin, even if it is become deeper, if you can raise a bleb like what I showed, that's the best way. And you can actually enucleate, and occasionally you can use scissors if the cleavage is not very clear. There should not be any ovarian follicles on the cyst side. Always check frequently, and you can find this 3-instrument positioning. Some areas you can find, this was the area where it was partly, there was an endometrioma, but it was a surface endometrioma. I did not actually excise this. And finally, you can find the ovary is well reconstructed, even without suturing. And this is the way I normally do. I have shown this. Always inspect your cyst lining to improve your cystectomy technique and reduce the ovarian tissue loss. Both surfaces should look smooth if you really want to use. I have already published the way the ovarian reconstruction. I have been doing it many years. And this is the recommendation from the SRI. Either you don't suture, or if at all you suture. I find many people suture like a gunny bag. You do a lot of retroperitoneal dissection. Finally, when you come to the ovary, you are so impatient, take a gunny bag suturing. That's not fair. Even if you want to suture, it should be inside the ovary, should be smaller than 2-0 vicryl or such sutures. This is where most of us find it difficult, or there is higher chance of recurrence. You can see multiloculated, but majority are less than 5. That is a standard rule. Very rarely it may be different. This is again actually an unmarried woman with endometrioma with the multiloculi, and you can see these ultrasound images, and she had already MRI images, so you can watch the MRI. It's a good practice to learn how to read the MRI by ourselves, and you can see that there is a big multiloculated. Whenever the cyst is very large, if you actually decompress, it will stain the whole pelvis. So better to use a trocar and decompress and wash it out. The main cyst lining. The technique is same. The first step is the salpingo-ovariolysis. You use a combination of blunt. Very rarely you need a sharp dissection, but here you find actually there is a lot of scarring where I have to use the scissors occasionally. And when there is a fibrous tissue, it has to be excised. You can find there is excision, and actually I'm injecting the vasopressin. this was unmarried woman, so normally we try to avoid uterine manipulation. You can actually take a suture on the uterus if there is a lot of POD disease in such cases, and the implants are being coagulated. Normally, I don't excise very widely and depatronize the pelvis, which some of the surgeons are very fond of. I think depending on if you are doing it for a recurrence or pain in such situations, definitely a good excision is better. But in routine cases of infertility where there is no pain symptoms, and the main technique of doing cystectomy in a multi-loculated one is identify all the cysts, and you open up all the cysts and try to combine as far as possible, but should not lose. So every loculi you must identify preoperatively as well as intraoperatively, and then do the enucleation. This 3 instrument, don't try to do a endometriosis enucleation with the 2 instruments. Just adding one more trocar will not do any harm, but you will have a very fine control of cystectomy in this case. And now the second loculi. So you might have already opened and widened. So it's very easy to, otherwise sometimes you may lose track of the loculi and end up in retaining few of the loculi, and the patient come back with the endometrioma within few months. That should not happen. Many people try to put them on GnRH. I don't think that's a good option. You should do a thorough job without losing much of the ovarian tissue. So identifying the loculi, opening the loculi intraoperatively and keeping it, then you decide how to do the enucleation process. Again, already I mentioned the trimming of the edges, trimming of the implants before you actually, you can see that sometimes the tip maybe have a very thin layer of endometrioma, cyst lining, which you may not be able to actually enucleate. So in those cases, trimming that edges, but you can see that it's very little bit of thin, papery thin ovarian tissue I am. Then reconstruction of the ovaries, something like an artistic job. You try to find out, the main aim is you must avoid you must keep a normal ovarian tissue where your fimbria is going to move. That is going to give you the best pregnancy outcome in such cases. I have many times, this may be a deceptive. Sometimes you may find diagnosed in endometrioma and you end up in endometrioma instead of endometrioma and abscess. Most of these patients have already operated, and if you take the history of this patient, many a time the pain has no relationship with the menses. It is almost same, except little bit of exaggeration during menses or just before the menses. And many a time the classical feature is, if you put them on GnRH or Dinogest, this pain will not disappear. That is one clue that the patient may have an ovarian abscess rather than endometrioma. And if you take the history, they will say they have occasional low-grade fever, and the CRP need not be raised all the time because this patient might have repeated doses of antibiotic whenever the patient comes with a pain and fever. So the first step was draining the chocolate cyst. This is an infertile patient, and we never had taken permission for doing adnexectomy. Even if you ask for the adnexectomy, the patient will not agree for that. And we normally try to conserve the ovaries, do a cystectomy, even in cases with ovarian abscess. I removed both tubes, and you can see that how we go about with an ovarian abscess. But definitely it's a chronic abscess, so you will definitely get a good cleavage. You can see this is the abscess cavity, and you can see the thickened endometrioma wall with the abscess, and you can very easily enucleate. Although we expect a lot of difficulty, definitely it will be more vascular, so we may use repeated dose of vasopressin because we normally use the vasopressin only to blanch the tissues. Once it blanches, we stop and we do a repeat step, and we could conserve. Many of these patients may have a stormy postoperative period, which comes out very with a few days of antibiotic. Sometimes you might have found patients who complains of acute abdominal pain with a large endometrioma, and they normally do a CA125 and you find it is about 1000. So I think most of these cases are actually leaking endometriomas. This, I think, some 15 centimeter endometrioma is quite big one, and you can see the whole staining of the abdomen. This is the leakage of the endometrioma into the peritoneal cavity, which has caused the pain, and this is the construction. We actually did only cystectomy. That's why, even though it was a 15 centimeter endometrioma, the ovary looks bigger. And it's very important to check the kidneys, and you may find there may be hydronephrosis and hydroureter. This is a case of similar endometriosis with hydroureter. And we plan for left adnexectomy and ureterolysis. I think now all the younger crowd is trained on retroperitoneal dissection. All of us have to learn this, because occasional cases we need this, and you have to release the rectosigmoid medially and expose the hydroureter. Hydroureter is very easy to, it looks like, don't look for the normal ureter. It's actually too much dilated one, and you can actually watch the hydroureter. It is sticking to the peritoneum, but you can see it's quite distended in the upper part. You can see the psoas muscle and the hydroureter. Now you have to identify where actually the fibrosis or kinking of the ureter has happened because of the endometriosis. You can see it's dilated. You have to trace it down, and you find in the lower part, it is actually of normal caliber. This patient has agreed because unless you remove, there is a large adenomyosis, and the patient want to retain the uterus. I think she has secondary infertility, but she has already one child, and she agreed for left adnexectomy. And the next step is actually identify where exactly is the constriction. Actually, you can see a constricting band, a fibrous band, and you can see the small caliber. And once we remove the fibrous band, we put a ureteric stent in this case, and the ureter came back to normal size. We removed it after 8 weeks, and she's doing well. To conclude, a good preoperative evaluation is the most important part of doing an endometrioma. Just don't walk in like a normal ovarian cyst, and the surgical treatment, cystectomy, is still the standard of care. You have to make all attempts to reduce the ovarian damage using vasopressin as well as fine technique. And you must consider older patients, small cyst, multilocular cyst, bilateral cyst. They are the one who is going to have a loss of AMH or reduction in the AMH, and you have to be more careful in this age group. And it's preferably do an AMH before surgery. Sometimes it may take few months to return to have a improvement in the AMH and minimal diathermy damage. So thank you all for the patient attention. I thank Ashwath and team for giving me this opportunity.
Thank you, sir. And now Hari Prasad, sir, and Ajita madam. We can take few questions as we are delay. There is a delay. We will at least have few questions.
Dr. Hafiz. Yeah, Dr. Hafiz, what is your choice of mesh repair in nulliparous uterine prolapse, or those who want to retain fertility?
Yeah, same thing which we have shown. No, that is a method which we have shown actually. It's an nulliparous uterine prolapse where we have retained the uterus. See, the only issue with this method which I've shown when we take the muslin tape around the cervix is that we have to have a C-section. If the patient goes for a fertility, she should have a C-section. But the advantage is that there is absolutely no failure because the muslin tape cannot cut through the cervix. If you fix it to the posterior alone, there is all chance of the muslin tape cutting through the tissues.
Hafiz, can I make this muslin tape? Are you happy with the muslin tape? Because occasionally muslin tape has more rejection than the mesh.
Yeah, muslin tape has more rejection, but when you are putting in the cervix, till now we didn't have any rejection. But the problem is we don't have any tape like that. We don't have any tape, or else you will have to use the Gore-Tex sutures, which are thick white sutures. Okay. If you use a thin suture or a Prolene or a Ethilon, there is higher chance of cutting through the tissues compared to a tape. Or else you'll have to take the mesh around the cervix and fold it.
Okay.
Ajita madam?
Yes.
Anything is
The question to Paul, sir. Paul, sir, do you always repair the ovaries after you remove an endometrium?
Yes. Reconstruct, no?
Reconstruct.
Yes, I reconstruct. Because I personally think that if you can reconstruct the ovary, it forms into a normal ovarian shape faster than, there are techniques I know that you just do the cystectomy and leave it. But I think surgical
reconstruct means, do you suture it?
No, I don't suture. Very rarely.
Yeah. Means you just keep it closed.
Just closed and use the natural fibrin to act as a glue and it remains there.
Okay.
Dr. Paul,
yes.
For endometriosis, the first surgery is the most important surgery and there is no second surgery for endometriosis. And for the success, do you believe the surgeon should do the ultrasound scanning prior to surgery and delineate all the lesions?
I think I already highlighted. It's very important because for the sonologist, it's not very important. For us, any loculi you miss can end up in recurrence and incomplete removal. So it's always do a scan yourself. We normally do a scan on the day of surgery or previous day to make sure things have not changed. Probably you might have seen that patient maybe 2 weeks or still earlier.
Thank you.
Adulya, project the CV slide of Krishna Kumar, sir.
Sir.
Krishna Kumar, sir.
I think
sir, I had Krishna.
There was a question
problem.
Dr. Hafiz, no? Do you have any mesh-related complication? There is a question in the chat box.
Okay, Hafiz, sir. There's one more question for you. Mesh-related complication, anything you had in your practice?
Mesh-related complication, we had one mesh-related erosion into the bladder because basically because of the abnormal planes which we chose. And we had one case of mesh infection where it is not an erosion, basically it was an infection where we had to remove the mesh completely. But I have seen a lot of mesh-related complications which has come from outside. It's not my own complication, but a lot of it which has come from outside where it needs correction. All of them, I think the only treatment will be initially to remove the mesh completely. And one surprising thing which we have seen in these cases is that even after removing the mesh, many of them, the prolapse has not still recurred. Even after we remove the mesh and detach it from the sacral promontory and removed it completely, the prolapse usually doesn't recur 100% as we think. It still stays there for almost 70% of the patients.
Okay. Shall we move on to the next session, because there are so many questions, but we could not because of the lack of time. And it's the most prestigious to have our IAG president in KCOG. Last year it was Sunitama. Now we have Krishna Kumar sir to deliver the keynote address of the day. Krishna Kumar sir, as you know, the most important is that I present IAG president. He is the chief consultant, JK Women's Hospital and Fortis Hospital. He is a president. He was Secretary General of. He is the Secretary General of ISAR from 2018 to 20. X-ray certificate, reproductive endoscopic course, center recognized by ICOG fellowship, 6 months, IRT endoscopy, Foxy recognized center for infertility and endoscopic surgery, special interest naturally endoscopy and infertility and recurrent pregnancy loss, National IMA award, special award for eminent medical men for distinct use. So many awards to his credit, and is a more important is those who know Krishna Kumar sir, he knows that he's such a down-to-earth person. Anybody can talk to him very freely. Even a junior calls him for anything, and the IAG has, during this corona period, as he has taken over IAG, is doing so much activities which we could not imagine. So we thought that endoscopy is something even we are having live workshops. So every month we are having live workshops, different innovative programs. So today when I wanted the keynote address, he told something special. I will talk on robotic astroscopy. Even I have not heard about it. Something new. We would all, and so many of the postgraduates and consultants called me today and asked that what is this robotic hysteroscopy. So I told wait till evening so you can hear. So most of us doesn't know what it is, and it will be very nice to hear from Krishna Kumar sir. We know robotic now, but robotic hysteroscopy, many of us hearing for the first time. Krishna Kumar sir, we are so privileged to have you in Kerala for our state congress to deliver our keynote address of the day. Krishna Kumar sir, the podium is yours.
Thank you, ASWATH, for those kind words. And thanks to the Kerala Federation of Obstetrics and Gynecologists for having me here in the All Kerala Obstetric Conference. And thanks for the kind words. And thanks to the President, Dr. Ambujam, Dr. Ajit, the incoming President, and Venugopal. And of course, millions of thanks to ASWATH and other friends, SUBASH, who specially called me up and said that the keynote address we want you to have. So I thought of suggesting something new. Let me talk something different, robotics in hysteroscopy. And the immediate reaction was, are you kidding? Means, are you really joking or something? But yes, at this moment, it looks like a joke, but very near my future, I think we will have something in hysteroscopy too. Well, the advantage of laparoscopy is now well known. I don't have to really tell. Of course, eminent surgeons like Hafiz, Paul, and Shailesh, everybody will say robot is not required in laparoscopy, but it has some advantages, better dexterity. It dances inside the abdomen so beautifully. You can see it's like a music, but deep pelvic access, the accessibility becomes very easy, many people say. And those who have shifted from conventional surgery to laparoscopic surgery, they say robotic surgery is more easier to learn. And of course, as age increases, some other advantages, the tremors you cannot see them because you're sitting away from the patient inside the console. So those things are some of the advantages of robot in laparoscopy we know. But basic advantages, you have easy accessibility into really difficult areas. Now, coming to hysteroscopy, today I can proudly say that it is now also called the stethoscope of gynecologists. No gynecologist can be away from learning hysteroscopy because it has made us complete. Imagine 40 years back when we started, or 30 years back, and I started as a resident, most of the intrauterine pathology were inaccessible. All those difficult or those simple looking septum and uterine anomalies, the Tompkins surgery, a Strassman metroplasty, I never used to understand those days as a resident. I said, so difficult to tackle such a small lesion. Patients coming with polyp, do a blind DNC, patients come back with bleeding, do a hysterectomy. So either we were doing incomplete treatment or over treatment. So definitely we have to know that hysteroscopy as what made the gynecologist complete. Otherwise, how can we answer to the patient so many things we have no access, I can't answer. And definitely we are blessed with all those innovations in hysteroscopy today, smaller diameter, better energy applications, friendly, smaller diameter resectoscope have come, 14 French, 15 French, from that larger 26. And of course, the advantage of intrauterine morcellators and so many things. I wouldn't go into details because of the very short of time. And definitely, we are all blessed with these understanding which we have today. And of course, you will agree that surgical interventions have been restricted to linear movements. Whenever we have to do something inside the uterine cavity, we cannot, use two hands. And we have with only one instrument, which is hardly 2 millimeters. Such small polyps also, it becomes so difficult. Even if I don't have to use energy, you can see if I had another hand and pull that polyp up, it would just be a minute. I just cut it off, like we saw Dr. Paul doing resection of endometrial cyst. Counter traction, traction is the basic principle of any surgery. So if you are able to have two hands, you can lift it, pull it the other side and remove it off, and the surgery also becomes better. Energy also, if I have to apply, I can apply it perpendicularly, it will have less thermal damage. All that is not possible at this point of time. And after removing these kind of polyps, we struggle removing it with all those various kinds of graspers and trying to pull it. So definitely two hands inside the abdomen would be very, very great advantage. So as I said, we are all blessed today to have such beautiful surgeries being, be able to do inside the abdomen because of all these smaller diameter scissors and electrodes and this small Gubini resectoscope. But even that Gubini resectoscope in a postmenopausal patient, you can see it becomes so difficult because the polyp keeps on moving and your resection is not that simple as it looks like. And we waste more time. And more time in hysteroscopy means inviting more trouble of the fluid complications. But if you had something where you can absolutely regulate all these things by just having some extra hand to pull it, push it, you will be able to do faster. Now we are able to do with all these expertise, even in cases of difficult Asherman, as you can see there, just the scissors doing that magic, enter the proper cavity, you can enter and you can do some of the most complex hysteroscopic surgery. But I would always wish I had additional hand inside the abdomen, inside the uterine cavity, like we have an additional chance of, trocars, you want multiple trocars you can put and complete any complex laparoscopic surgery. Hysteroscopic surgeries are simple. They have to be done in 15-20 minutes. You can't delay because of the complications which all we involve. But all this is not possible because of this simple reason, because all these innovations have been limited by the size of the uterine cavity and the need to access this space by the device, which also serves to provide vision and exchange. I mean, you need a telescope, you need a media inside it, and then you have the 2 millimeter instruments only possible inside it. So today, why should only robotic should be there in laparoscopic, and why should only laparoscopic surgeons all have all the fun inside? Because sometimes it looks like just you're playing inside the abdomen, sitting inside somewhere away from the patient, and you don't think you are a surgeon, you're somebody just playing some video game. You are having the fun sitting far away. Why should only laparoscopic surgeons have all the fun? And that is where people are working on developing something for the hysteroscopists. So that's a good news for the hysteroscopic surgeons who believe in more of hysteroscopy, that they can have something similar to what the laparoscopists have. Robots, so those who can afford are having robotic in laparoscopic surgery, but very soon we think, I'm sure that it will come to the hysteroscopy too. So I'm just going to show you some glimpses of what is coming or in store for us. Well, adaptation of the same principle of robotic endoscopic surgery will definitely enable enhanced surgical techniques and capabilities of the hysteroscopic surgeon. There is no doubt, I'm sure, in everybody's mind that if I can have two instruments, definitely you will have better exposure, finer dissection capability, because you can lift, you can pull, you can, pull it to the other side when you're applying energy, and definitely a two-handed surgical technique will always be more safer and faster in any surgery rather than that single hand. So just to demonstrate how, see a polyp which is there, you can have an instrument which is either a probe or you can have a grasper just to give traction, and you can apply energy with your other hand, and definitely this will be the dream or requirement every hysteroscopic surgeon will want inside the uterine cavity, where you can pull on it, push it, and give a good traction, and then apply safe energy more perpendicular to the tissue. So this is all what is robotic astroscopy. So how this two instrument can come in. And of course, I don't want to be near the patient. I can sit away from the patient and do. So that is what is robotic astroscopy is about, like what is already happening in laparoscopy. You can see how beautifully you can just pull it, and by the traction itself, many a times such softer tissue will get cut a little, and you can apply much safer energy and not have the fear of damaging the adjacent endometrium, which is so much talked about in patients, especially in the reproductive age group. And that's it. You can cut it and then decide how you want to remove it. So you have two hands working on it. So is this possible? Yes, this is an ideal setting. So you have, apart from the telescope, you have two concentric tube manipulators, of which one of them can telescopically extend and rotate inside. You see these two rods apart from the telescope. So one of them can even go and have the grasper like this. You can hold it, twist it, and give traction and counter traction. Well, this is what the console is. You can sit away and you can control those two instruments inside the uterine cavity, not really standing next to the patient in between the two legs. So that is what is in store for us. And this is how the whole console is going to look. You can have these two here, anywhere away, and then this is the actual, the arm of the hysteroscopy with those two instruments and the telescope going into the patient's pelvis uterine cavity, and you sitting away from it and operate. And this is how you can see the actual video, how with the left hand, you are able to control the left hand instrument, and with the right hand, one can use the energy, and the same thing movement as it is done in a robotic laparoscopy is all possible in hysteroscopy, and is going to come out soon is what the evidence, the experiment which is being done in certain places. They are all very confident, and definitely it may not be as complex as what a robotic laparoscopy is required, because there it is going to be much more complex, whereas a hysteroscopic robot can be of less complexity in nature. But you can see how beautifully you can sit down, do it comfortably, far away from the patient, and still have the same control inside the uterine cavity, which is such a narrow cavity, and so much safety precautions are required as far as not only applying energy, but definitely the fluid complication. And definitely this surgery will be faster and quicker and what is the conventional hysteroscopy, and definitely will be a great advantage even for larger lesions, because you can be faster and in your action, and you can see, once you cut it from above, you can go below by just pulling it upwards and then apply energy if required, or by the scissors you can cut it and do the job completely. So this is what robotic hysteroscopy can really offer to us. And why should we not have it once this is all ready and come to the market? And definitely, I'm sure hysteroscopists also will have all the enjoyment, fun of robotic surgeries. And this is, of course, there are certain articles. This is one of the latest articles in JMIG journal, which also convinced that at Tennessee, There are a lot of experiments which have been done, and it's already the prototype is ready, and very soon maybe it will be marketed. So potential advantage, my friends, improved vision by uncoupling the telescope from the hysteroscopic instruments. You have better exposure with finer dissection capability, and definitely two simultaneously controlled instruments to enable counter traction, traction, the basic principles of surgery. And definitely it offers ergonomic advantages to the surgeon by allowing them to control at adjustable height and sitting comfortably far away from the patient. And as far as the cost is concerned, it will be much, much cheaper, they say, because it's significantly less complex than the other robotic system. So cost could be appreciably less. So this is definitely, isn't it exciting to you all? It is definitely exciting to me. So this was a very small introduction on robotic hysteroscopy to you all. Thanks for a very patient hearing. Thank you, Ashwath.
Thank you, sir. You can now. I just want seniors are there. Kurian sir, Paul sir, Hafiz sir, and Jagasan sir are there. Just one comment. Kurian sir, see something new technology. You are coming. Kurian sir.
Yep. Good evening. Nice to hear you, Krishna Kumar, on that.
Good evening.
Interesting concept. Only thing is, we may want to have the uterus much larger because there's no space to move. And that's going to be one issue. And the second issue is that the axis of the uterus keeps changing. As it changes, at times when we started initially with the flexible hysteroscope, we found we were getting lost. We didn't know where the ostia was, if that uterus rotated or got retroverted. So both were problems. I'm sure you will get over all these things. Maybe in your term itself, we will have the robo coming in for it.
I hope so.
Paul sir, your comment on it.
Very impressive. But even laparoscopy, I have not tried on robotics. But I am really impressed. We should have all this because every day in life, even on car or at home, we use a lot of something similar to robotic. So why not it should be in the surgery? So we hope for such improvements, at least in our time itself.
Yes,
Officer.
Yeah, it is definitely going to come up. There is no doubt. But the biggest problem with this histoscopy is that, see, initially our biggest problem with histoscopy was the cervical dilatation and damage. The damage the resectoscope creates to the cervix is much more than what we used to actually understand. So that is why we kept on reducing the size of histoscopy, and we were able to do a lot of diagnostic, and then we kept on reducing the size and shape of the structure. You know, we had a smaller shape for the grasper to go so that we were able to go inside easily without damaging the cervix. Now with the introduction of robotics, definitely the size of the instrument is going to be a little more bigger, at least initially. Maybe later on you might reduce with the introduction of new metal or new elements which will be much more tougher in the smaller size. But right now that is going to be the biggest challenge. We'll again go back to the large instrument which goes into the cervix. And another thing, Krishna Kumar, see, we were all taught that you should not cut the pedicle of a large lesion, except maybe if it is a mucus polyp. If it is a fibroid, you're not supposed to cut it. You have to just cut it slowly and mosellate or take it. If you cut the pedicle, then it will be much more difficult to take it outside the uterus. So here we can see that robotics, the only advantage is, see, you don't have much advantage in septum. We don't have much advantage in addition because the uterus will be distended and the additions are in front of us. The only advantage may be in larger masses, which we can shift it to one side. But that also, if we are looking at cutting the pedicle, then it may be difficult to remove it.
No, definitely, cutting the pedicle is not the answer, as you rightly pointed out. Definitely slicing it also, you will have a better hand if you have two hands to slice it faster. But the main challenge, as you said, is the diameter, which can be a big challenge, because as you said rightly, because the reduction in diameter, we are more happy with hysteroscopic surgery. So when you have to have two instruments, definitely the diameter has to become little bigger. So that is where the challenge is, but definitely something interesting which is being worked on. So let's wait and see.
Hysteroscopy usually is a very fine surgical technique.
Right.
You have to be very fine. Most of the time, I've seen people dilating the cervix too much and damaging the entire cervix. Even endometrium also. I've seen people doing a myomectomy and they would have taken out half the endometrium. So these things are, it has to be a very fine surgery compared to laparoscopy.
We have been enjoying hysteroscopy because of the fineness which we are getting with the smaller diameter instruments and tweezers, and we have learned that trick. Yes.
So now you are going back to the bigger one.
Right.
Anyway, thank you, Krishnawar sir, and Hafiz sir, Paul sir, Kurian sir, and all of you for giving your comments. And it's a very interesting thing, something new sir has presented. Thank you, sir, once again for taking your time and be here with us. And now everybody is waiting for the next session, which is a panel discussion by Kurian sir. One thing I should, anybody wants, one thing I should
Yes,
say
sir.
about.
I would like to thank Krishna Kumar sir for that wonderful talk, sir.
Subash is here. And Kurian sir, every AKCOG, I have not seen the last, whatever I remember, the AKCOG, there was not a single AKCOG where Kurian sir has not been faculty for us. And it is a routine that AKCOG means first we will call Kurian sir. And he never says no, he will adjust somehow and come for the workshop as well as give 2-3 lectures also wherever we wanted. So this time also, he told that we told him we wanted the panel with him. It will be for 45 minutes to 1 hour. He was so happy. Sorry that we had a technical delay in the beginning, so there is a delay of 20 to 25 minutes. We made you waiting, Kurian sir, and the whole panel team. So I will be happy to introduce Kurian sir. He is the director of Joseph Hospital, pioneer in endoscopic surgery in the South. From 1995 has trained so many doctors, not only from India and abroad. He was the most prestigious. I think he was president. He was very few people have become the president of AFOG. He is one of the Indian who have become the president of AFOG. Then international ISG member, board member, Foxy vice president, organizing committee of ASUG. We had a very nice ASUG, one of the best in 2015 in Chennai. Then he is obstetric and gynecology past president of South India OGSSI and the chairman of the Tamil Nadu chapter of IAG. So many credentials to it, so we will not be able to, the whole 10-15 minutes it will take enough to read the biodata of Kurian sir. So before Kurian sir starts his panel discussion, Subash will in short introduce all the panelists for you, sir. Subash. Adulya, next slide.
Thank you, Ashwath sir. One more thing I would like to add about Kurian sir's AICOG was it was the most profit making. It was about 3.01 crores. So let us not forget that. Sir, I have the proud privilege of welcoming Dr. Jayashree Madam. Madam is a professor and unit head at Government Medical College Trivandrum, and Madam is one of the very enthusiastic endoscopic surgeons in and around Travancore area. And it's been a privilege. I've heard a lot about Madam. I've not seen, but I've heard a lot about Madam surgeries from my friends, and it's a privilege, Madam, to have you here. Next, I would like to welcome Sandeep Roy. Sandeep is a good friend of mine and is an endoscopic surgeon at Trishur. And I would like to call him as a pan-Indian from Tripura, hailing from Tripura, studied in Manipur, married a Punjabi, settled in Kerala, studied in Bangalore. So it's a pan-Indian for that matter. Right. I would like to call upon the next speaker, Dr. Minupriya. Dr. Minupriya is a consultant at Benzer Hospital, Kollam, and she is a proud protege of Hafiz Rahman sir. And she is doing a lot of wonderful work back in Kollam and that area. And it's a proud privilege to welcome Dr. Minupriya also. Again, next I would like to welcome Dr. Cyriac Papachan. We all know about Cyriac, the dawn of Adur. So the endoscopic dawn of Adur and Central Travancore. It's a proud privilege to welcome you, Cyriac. We all have very good memories of Endo World all along. And once the corona settles, we are sure we'll have one more Endo World. Next, I would like to welcome Dr. Praveen. Dr. Praveen is an endoscopic surgeon at Trishur and is doing a wonderful work over there and is a good friend of mine, and I have the proud privilege of welcoming Praveen also here. Next, we have an international faculty, Dr. George Paul, who is currently at Dubai. And I have a proud privilege of welcoming our foreign faculty, Dr. George. Dr. George is a consultant at Dr. Paul's Hospital, Kallur, Cochin, and is a very good friend of mine. And I would like to welcome Dr. Paul for the show. Kurian sir, over to you, sir.
Yep. Stop sharing the screen. Good evening. You can see the pictures clear. So every cloud has a silver lining, and part of this lovely silver lining is in this pandemic time to tell you that a new species of butterfly was found at Agastya Mala, and this is between Trivandrum, between Kerala and Tamil Nadu. It's an absolutely beautiful butterfly. I'm sure you can appreciate the beauty, and this is exactly what KUFOG is to me. I want to congratulate KUFOG. Thanks for the kind invitation. And I always enjoy meeting up with all the stalwarts of KFOG, starting from Dr. Rajan right now to Professor Paili and all the current stars of KFOG. I wish you will keep calling me even in future. So with this in mind, I sat thinking of the management of fibroids. I was sitting in my house and I saw a startling bird outside. This is in Chennai, in my house itself. You can see the bird. It's an absolutely beautiful bird. And the first question to the panelists is, would you know what this bird is? I'm sure my panelists are not bird watchers, and I'm sure at least the men would see other types of birds. Anybody wants to guess, you're welcome to guess. This bird is the paradise flycatcher. It's a bird from the northeast of India, which has apparently come down south, and I saw it. But the beauty about the bird is the fact that this is the male. The males are always smarter and better than the females. So this is like the peacock story. So with this in mind, I've got 6 experts on fibroid selection treatment dilemmas. To operate or not, how to prepare, how your surgical technique varies with the different cases. You follow up later for pregnancy, any other option. For this, I have a very illustrious panel. You can see you've been introduced to all of them. Most of them I know very well. Most of them do wonderful work. And we are in fact watching some of them operate and trying to learn from them as we see this. But the cases I'm showing you are just few cases which I've had in the past few days. Each one, some will be irritating, some will be interesting. But whatever it is, we'll try and take home some messages from that. To the panel first. Let's start with Dr. Jayashree. You are all aware of the international classification of myomas. Would you like to tell us what you would like to do, or rather how you would like to remove a type 0, a type 1, and maybe a type 2 myoma? Dr. Jayashree, please.
Yeah, for the types 0, the best is always histoscopy. At 0, 1, and 2 probably. 2 probably you may have to have it in 2 settings. Sometimes it may not come out in 1.
Okay, so you'll be prepared. Remember the size of the myoma, just 2 to 3 centimeters.
Yeah.
Okay, let's go to Dr. Sandeep. If you have a myoma which is a little more intriguingly placed, say a type 4 or a type 5, how would you like to take it? A 2 or 3 centimeter myoma? First, will you take it out or will you just leave it alone?
I think a 2 to 3 centimeter fibroid, we have to see what are the symptoms of the patient. So if the symptoms are not that serious, probably we need not to remove a 2 to 3 centimeter fibroid, and we can just counsel her for regular ultrasound.
Yep.
So good. Probably that is the approach I'll follow, 2 to 3 centimeter fibroid. Yeah.
We agree with you on that. Let's go on to Dr. Praveen. What about a larger subserous myoma, 5 centimeter number, a type 5 or a type 7? What would you like to do? Dr.
So again, it depends upon. Yes, sir. Am I audible?
Yeah, I can hear you. Go ahead.
Yes, sir. Again, it depends upon the symptoms, sir. Like if the patient is having any pain, normally type 5, type 7 won't be having any abnormal bleeding.
Okay.
If they are causing any pressure symptoms or pain, then I'll go for surgery, that too by laparoscopy, sir.
Okay. Okay, let's go to Dr. Minupriya. You have a slightly more tricky question. What about size 2 to 5? What extends from the cavity to the subserosal layer? Dr. Minupriya, around? Welcome from Kollam. I can't hear you. Okay. You're there?
Dr. Minu, you'll have to unmute.
Okay, yeah.
Okay.
I've unmuted myself. Can you hear me?
Yeah, I can hear you now. Go ahead, please.
Okay.
Yeah.
So your question is for a 2 to 5 kind of fibroid, what will be my management?
Yeah, that's right.
Again, sir, it will depend on the symptom of the patient.
Yep.
If the patient is symptomatic and if she has abnormal uterine bleeding, in these cases, most women will have abnormal uterine bleeding. And such cases, I would go for a laparoscopy and go ahead with a myomectomy.
Would you like to start with hysteroscopy and then go laparoscopy?
Yes, sir. Always start with the hysteroscopy. I would see for the hysteroscopic image and then again combine it with laparoscopy.
Fine. Dr. Suryak, the cervical myoma, a large cervical myoma, laparoscopy, any other option?
Yes, sir.
Yep, I can't hear you.
Vaginal also we can plan, but I'm very comfortable. Hello?
Yeah, go ahead. I can hear you.
Hello?
Right, good. Yeah, I can hear you.
Hello, can you hear me?
I can hear you, Suryak. Go ahead, talk.
Yeah, for a cervical fibroid, if it is symptomatic and if the patient definitely has to undergo a myomectomy, then definitely we can plan laparoscopic myomectomy, or else we can plan even vaginal myomectomy.
Okay, good. So now we've got all
But
these...
I am very comfortable with laparoscopic myomectomy, so I proceed only with laparoscopic.
Okay. So George, you've got a scene where a 37-year-old married for 9 years. She tried all fertility things, did not work. She's now preparing for IVF. She has had a lap myomectomy in 2019.
Hello.
And in 2020, she has had a hysteroscopic myomectomy. Today, she's got a slightly enlarged uterus. She's got multiple myomas all around the uterus. The endometrium is not enlarged and both ovaries are normal. The MRI also confirms the findings. What would you like to do in this case?
There's an endometrial polyp, isn't it?
Pardon?
Endometrial polyp.
There is an endometrial polyp. 15, you can see that, no? Right? Yeah.
So ideally, that polyp has to be removed.
Yeah, polyp has to be removed.
Has to be removed.
What about the fibroids? I can't give you a simple question, no?
If these are all intramural, that shouldn't be affecting it much. But then since we are doing a surgery, might as well we can do a laparoscopy along with that.
You want to do a laparoscopy? You want to do a myomectomy?
Yes.
I can give you the options.
But maybe remove only the major big ones. You can't go about.
You want to remove only the big one?
Yeah.
Okay. Any other option? Anybody else wants to comment on that? Yes, Sandeep, go ahead.
Yes, sir. I think in this case, the uterine cavity looks more or less normal on MRI. So we have only one polyp.
Okay.
So probably I'll go for a hysteroscopy and remove the polyp and counsel the patient that probably will become pregnant and there may not be any issues. But again, there are some literature that says if the fibroid, even if it is intramural, if it is 4 centimeters or more, it is better to remove them before doing IVF. So I'll give that option to them. Probably I'll go ahead with an IVF. And maybe like if it fails or if it doesn't happen, then probably in the next setting, probably I'll go for a myomectomy.
So Jayashree, any comment on that? We've got 2 opinions now.
Yeah. Polypectomy, it's better not to disturb the endometrium much by doing maybe interfere with the IVF. So probably after polypectomy, that small polyp can be removed and then try for IVF. Considering her age, I think AMH may play a better role. Like that, we need to know prior to.
Well, they've already harvested the eggs. Eggs are available, or rather embryos are available. So what do you think we should do? Praveen, any opinion?
In my opinion, I feel along with hysteroscopic polypectomy, I would go for a laparoscopic myomectomy also, sir.
Okay.
And as much as fibroids visible, I would like to remove.
Okay. What is the problem you would see in that? If you do the laparoscopic myomectomy, when do you think she can try for about, you can put the embryo back? How long do you think it will take?
Another 6 months.
Pardon?
6 months.
So we'll have to wait in.
You'll have to wait. Yeah. So that's
Yes,
yes. Okay. So these are the pictures which you all have to worry about. So your options are repeat myomectomy, repeat hysteroscopy, remove the polyp, any medical treatment, and then proceed with IVF. So it's clear? Suryak, any suggestion?
Actually, the cavity looks pretty good.
Yeah.
We can even try for a first-time embryo transfer if the embryos are there.
Okay.
We can definitely try for an embryo transfer. If not, then we can plan for a repeat myomectomy.
Yeah. So
or at least we can do a pre-IVF hysteroscopy. We can plan. I think hysteroscopy alone will suffice if we are going for a repeat myomectomy.
Study the cavity. There's nothing peeping into the cavity. There's just a polyp there. Not a very troublesome polyp. Remove the polyp. And I'm very happy that most of you who are very enthusiastic laparoscopic surgeons have decided to err on the side of caution rather than be enthusiastic and remove the whole thing. So after polypectomy, patient has gone for IVF, she is being downregulated, and then the embryos will be replaced inside. So I think the message is that we must make decisions based on the need and not on what you can do. So with these two simple cases, let's start on with a little more difficult case. Can I start with Sandeep? Yes. Sandeep, you've got this patient who's a 27-year-old. She's married for 6 months with severe menorrhagia, uterus 18 to 20 week size. There are 10 to 12 fibroids ranging from 1 to 8 centimeters. The largest fibroid on the right lateral wall is about 8.5 centimeters, on the left wall 7.5 centimeters. There are about 4 or 5 other fibroids all over the place. LDH is okay, ovaries are normal, she is anemic. So when you get a complex picture like this, my first question to you, Sandeep, I mean, you have to remove the fibroids, I'm not trying to dispute that. What would you like to do by way of hemostasis for this patient?
Yes, first option is vasopressin, like that is the most commonly used technique.
Yeah.
And another thing is, since it is a case of multiple uterine fibroid, we can also plan for a uterine artery ligation.
Okay.
Or at least a uterine artery compression during the surgery. So that,
you're saying compression or ligation or both?
Yes, sir. Ligation, we can give them the option because some studies, although not very high quality studies, they have shown that if you ligate the uterines in multiple fibroids, the chance of recurrence is reduced by 30-40%.
Okay.
So that option can be discussed with the patient. So that we can go ahead and do the myomectomy after injecting vasopressins. And we can use Bob suture, so that will help in faster and better approximation of
surgery. What about George? What about things like tranexamic acid, misoprostol? You don't like using any of those things?
Tranexamic acid probably might give you a very temporary sort of.
Only temporary. Okay.
I don't think it's as effective as vasopressin or uterine artery.
Okay. Suryak, if I ask you, what are your standard methods?
Sir, actually, when I see such a case, usually, if possible, I try for uterine artery occlusion with vessel clamp.
Okay.
Laparoscopy, I have the laparoscopy vessel clamp. I try to put that if for multiple fibroids, so that.
So that's bilateral.
Wonderful thing is that we have zero blood loss.
Okay.
In that particular case, my anesthetist, irrespective I ask him or not, he will give tranexamic acid.
Fine.
1 gram IV. So
Okay.
that reduces the blood loss. Then we inject vasopressin irrespectively for all the patients.
Okay.
That also reduces the blood loss to a great extent. So I think all these things together will help to reduce the blood loss to a great extent.
Fine.
Then fixing on to one particular.
Okay.
And misoprost also. We give routinely misoprost for all the patients.
So Jayashree, are you fond of uterine artery occlusion? Would you like to?
Yeah, I'm fond of injection with vasopressin. That I found more comfortable. Then in uterine artery clips would be better because she's a young woman planning for fertility.
Okay.
So rather than ligation, I think clips and later taking off after the surgery would be fine.
Fine. Dr. Praveen, are you fond of clips or do you like to ligate the uterine artery?
Sir, I don't do uterine artery ligation, sir, for my myomectomy cases.
Okay.
I use vasopressin and I use we use tranexamic acid, and we
Okay.
ask the anesthetist to keep the BP around 90 to 100. So
Fine.
with these things, we are able to manage our cases, sir.
Okay. What about you, Dr. Minupriya? Your favorite
Yes,
method?
sir. I use vasopressin. Again, uterine artery ligation I'm not doing, but I think it is a very good method to reduce the bleeding.
Fine, fine. Okay. So all of you are more or less in agreement. You prefer vasopressin. If you want, you think of uterine artery occlusion. Any other special way you would like to prepare for this particular patient? Any of you? Welcome.
Sir, all these multiple fibroids, big cases, we always give peg-leg anemia also.
Okay.
So that they can have a real good bowel control. We have a very good bowel control.
Right. Anything else?
Fibroid mapping is important. Like,
Pardon, I can't hear.
Myoma mapping. Myoma mapping.
Myoma mapping. You're seeing enough of the picture here. You can see enough. All the fibroids, everything is there. The MRI is there. Ultrasound is there. Anything further?
Sometimes these deep myomas you may not be able to identify during the surgery.
Okay, yeah, fine. Right. You'd like to map better. I agree with that. Perfect. Good idea.
Sometimes we can use an endoscopic ultrasound if we have like smaller fibroids. We can locate if it is there. Endoscopic ultrasound probe.
Okay, endoscopy ultrasound. Very good. Anything else?
This is good enough.
We can use a simple vaginal ultrasound also, transvaginal ultrasound also we can do.
For doing that, right. Any particular technique you'd like to start from the top below or below up, anything like that? What about energy source? None of you mentioned energy source at all. Anybody? Yeah? Dr. Jayashree, what energy source would you like to use?
For, you mean to say reduce the blood flow?
No, your favorite.
Harmonic
It's for monopolar.
Monopolar,
Cutting.
okay. What about you, Dr. Minupriya?
I think I would use the harmonic scalpel. Sir.
Harmonic, okay. Sandeep?
I use mainly this monopolar L hook, and sometimes I use scissor if the capsule is not very thick, so I go add with scissor.
Okay. Okay. So we are going into the surgery now. You can see the picture. So as I have gone in, you can see the fibroids, multiple fibroids all over the place. And we got some vasopressin, put vasopressin, and we were generally not very impressed because it didn't become as white as we wanted it to. Sandeep, what would you like to do in this picture?
Sir, I think all the time you will not get the typical blanching effect. I don't know what is the reason, but
you will continue the procedure.
Yes, I'll inject a little more of normal saline and try to get a plane, and then I'll go ahead with the surgery.
Anybody else would like to do anything else?
So identify the uterus proper and inject it into the uterus.
So what will you do? I can't find any uterus. I can see only these big fibroids there.
So try to identify the round ligament area.
Yeah.
And
I thought you saw it in that picture. You didn't see it. These two fibroids are at the fundus. The right side is 9 centimeters. Left side is 7.5 centimeters. The left side is cystic and has undergone degeneration. So let's continue further in the story. So after vasopressin, okay, good old monopolar, like a big hero cut. And as we cut, you can see, I mean, any of you can talk and tell me what is happening. There's nothing. It's absolute cystic, leaking all over the place.
Cystically degenerated fibroid.
Degenerated fibroid, yep. Now what to do? How will we get this mess out?
May not bleed
George,
much.
you're missing.
So if it is But the problem is we haven't seen the uterus properly. If it was quite serious, you could have cut along the base of the fibroid. But
Yep. So what will you do? So I'm cutting and you can see how much of trouble I am in. It's just pouring out like a tap everywhere, and I'm not getting the usual planes which smile at us when we cut a myoma. So I'm trying to cut more and more to see if there's something coming up. Yes, no? Quite irritating case, no?
Any GNRH taken patient prior to the surgery?
No, patient hadn't taken any GNRH. She's just been married for about 3-4 months. So what would you like to do at this stage? I've cut that myoma. It's open, smiling at me, but not coming out.
I think that's a jelly-like thing. So probably you can use a 10 mm suction, and if possible, you can reduce as much of the volume as possible.
10 mm suction into the myoma and take it out. Yes, good. Any other suggestion, Praveen? I'm sorry, I'm showing uncomfortable pictures because I had to show pictures which I am uncomfortable with. Praveen, please run away. I can't hear him. Anybody sitting quiet so far? Syriac? I've seen you doing some large myomas. You get a myoma like this, what to do? Can't hear. Everybody becomes silent.
Extend the incision.
Extend the incision for the other myomas.
No, you want to see that. You leave it alone and go to the other myomas. Good.
Look like a dumbbell.
Because all of you are experts. I'm not going to say anybody is wrong. Okay, I will go continue with my story. That's that same myoma. You can see how I'm trying to remove it now. Yep. So I'm using an instrument called a myoma dissector. Get into the plane and try and take that dirty bag out. So all of you have started praying that you won't get a fibroid like this. It's a nice fibroid. Don't get upset over this. Yes, Sandeep, any comment? Go ahead, talk.
Yes, sir.
You're all welcome. The audience wants to hear you, not me.
Yes, sir. I think this is absolutely a perfect technique, sir. If we can identify the plane between the fibroid and the capsule, then
okay,
we can dissect it.
Okay, good. George, any comment?
It is basically a cystic degeneration of the fibroid. So
yep, that's right.
So I can identify the cyst wall, fibroid cyst wall, and the uterine musculature. Then,
I mean,
so is it suction cannula you are using?
Some time. So actually, I left it alone and went to the other side, removed the other fibroid, came back, and then I could see some plane coming up here. So slowly the fibroid's been taken out. Okay. And once we took it out, you can see the next one is beginning to show its head up and take it out. So that's why I asked you all, would you use any particular technique to go through with this? So there you have the fibroid. You can see it's still a bloody mess. How would you have put your uterine artery clamp in these situations? Syriac?
It would have been quite difficult.
Because there's hardly any place anywhere around. Yeah. It's a big uterus. Okay? So that's done. Then we went to the posterior surface. Oops, sorry. I'm sorry. So when we went to the posterior surface, there were myomas, we took that out, and this is the completion of the problem. So thanks to your support, we could dissect. These were the 2 or 3 large posterior myomas we took out and sutured it. Any of you like to use anything to fill the cavity to make sure the cavity is obliterated? No suggestions? Nothing? Okay. Jayshree, you're very quiet. Any suggestion?
So we can suture in 2 layers, just not to leave in a dead space, that's all.
This particular case, do you think you need 2 layers?
This one is closing very quietly with 1 layer. It's going.
Okay. It's sitting quiet, no?
Yeah.
Okay. Then we found there were 3-4 myomas anteriorly, took them out, morcellated, and came out. I think the case is worrying you all. So sometimes people would love to help you, but just because of your nature and behavior, they don't. So because of my cases, I think you people are not going to talk to me hereafter. Okay, so let's go on to the next part of the story because I've been given only 45 minutes. Here we have a cystic myoma on the broad ligament on the right side. Fairly large, 8 into 9 centimeters. Any particular hemostatic method you would like to use in this particular case? You can see the myoma. It's in the... Yes, Dr. Minupriya?
Sir, because it is in the broad ligament, I think uterine artery ligation would help.
Okay. Unilateral, bilateral, and how will you approach it?
Sir, the unilateral, at least unilateral uterine artery ligation, especially on that side.
Okay. I have
Approach.
just injected vasopressin at the moment. Yeah, you can. I fully accept your opinion. You take it out. Dr. Praveen, you're around?
Uterine artery ligation.
Yes, yes, George.
Uterine artery ligation on the same side would have been quite difficult.
That's exactly what I'm asking. That's why I was sitting.
I think, sir, in true broad ligament fibroid, we have a very thin layer of peritoneum or sometimes a capsule only. So most of the time you inject a little bit of vasopressin in that, and that itself does some kind of hydrodissection, and we can remove it without doing anything.
I support your view, Sandeep. That's a good idea. So we have taken it. As we keep pulling it, more and more of the fibroid comes out. It's about 8 to 9 centimeters. Okay, that's the fibroid coming out. And it's pretty clear. There's much more of it down there. That's not the end of it.
Only thing is we have to be a little bit careful about not pulling the ureter down. So
Ureter, okay. I was wondering why nobody mentioned the ureter. If you go in the capsule, do you think the ureter will get affected?
No, sir.
Very unlikely.
Very unlikely.
Very unlikely. So you can see
and most of the time the ureter is pushed laterally. So
yeah. So that's why there's a very unusual position, but a very interesting position. Looks very impressive when you do the surgery, I suppose. So we slowly are getting the myoma out. No fancy gadgets, just vasopressin, and we are shelling it out. So while this is coming out, I'd like you to think of how to remove this fibroid also out. 8 into 9 centimeters. So that's the myoma come out.
Yes, sir.
Nice.
This is a morcellation.
In that morcellation.
We can do a morcellation of this fibroid. Yeah.
Okay. I'm a very old-fashioned man.
So you can do a colpotomy and vaginal retrieval.
The cystic myoma.
So probably get compressed.
It gets compressed and you can pull it out very, very easily. So you're seeing the pulling out. The shape is also favorable. And the whole thing just slips out before you know what's happening. And then you can suture the cavity shut with that. Agreed?
Yeah.
Okay. Any other suggestion? Any other method you would have thought of? I agree with the in-bag morcellation, but I think that's making my work double. All right? Yes, any other comment? All of you have become very silent. I don't like it.
We were looking into the procedure, how it's being done, how it is delivered.
Okay. Thanks, dear. Thanks, Jayashree. Okay. Okay, let's go on to the next part of the story. So tissue removal, we have sorted out. So I bring you greetings from Tamil Nadu. This is the state flag or flower of Tamil Nadu is called the flame lily. I don't know if you all have seen it. You would have most probably seen it in a field. Okay. Now I'm going to a very, very confusing case. Please don't blame me if it is very bad and irritating. 31-year-old married for 6 months with severe dysmenorrhea. 2013, that means fully 8 years ago, she underwent myomectomy, 10 centimeter fibroid removed. 2019, recurrence noted, repeat myomectomy done at 10 centimeter and a 5 centimeter myoma removed. Both were done laparoscopically by my colleagues somewhere in the Kobe region. Now in 2021, it's come with a recurrence. And somebody from there has very sweetly sent the patient to me. And this is the picture. So what we did is we first did a scan in our place itself. This is the thing to show you what it is. There's a large myoma anteriorly, a big growth of the fundus, and multiple small fibroids all over the place. Okay? You're with me? Right. So let's continue further. What would you like to do? Straight away, a repeat myomectomy? Or do you want to investigate her further? If investigate further, how? And what else would you like to do?
I think we'll go ahead with an MRI and
you want to do an MRI? Yep.
Yes, sir.
Then?
And do a proper fibroid mapping and and second thing, tumor markers like LDH, etc. All those things can be done.
Fine. So
And
you told us myoma mapping, you told us MRI, and you told tumor markers. Yep.
Yes, sir.
Surya, any comment?
What's the complaint?
She's severe menorrhagia and fibroid. She's wanting to have a baby. She's been married just for 6 months.
Was there any abnormality with the previous histopath?
Any abnormality with the?
In the previous myomectomy histopathology report, is just normal myoma?
The report which I've got are both saying it's just normal myoma, nothing else. Yes, George, you're sitting quiet.
Like the only option is to do another myomectomy.
Another myomectomy straight away? You don't want to investigate her further?
Like Dr. Sandeep said, MRI and all the tumor markers, obviously.
Because if you don't, you're going to give it to midway through, you'll call your father and give it to him.
Like Dr. Sandeep said, definitely do the MRI. You have to do all the tumor markers.
Okay.
Everything is all right.
Any other opinion, Dr. Minupriya?
So again, I think I would go with MRI, a proper myoma mapping, and follow up with surgery.
Okay, fine. Dr. Praveen, welcome back. Any suggestion? Yes?
Like she's married only 6 months and she has a heavy flow, as you
lost my
said.
connection. I'm not getting the question.
Yeah. So, what do you want to do, Jayashree?
Because she's only married 6 months, and why straight going for a myomectomy first? We will evaluate her cavity first. If the cavity is not much involved, why can't we wait for some time to see whether she'll conceive or not?
With the myomas as large as 8 into 11 and 7 into 9 centimeters in the cavity. Okay, I'll take you through the story further. Let's go on further. MRI done. Dr. Jayashree, you can read the MRI report. Large, markedly heterogeneous lesion predominantly arising in the anterior left lateral myometrium from the fundus to the body of the uterus, enhancing solid areas in the superior half, necrotic cystic lesions in the lower half of the lesion. There's a breach of the junctional zone of the fundus with involvement of the myometry, of the endometrium. So you can see the myoma on top, you can see that the endometrial cavity, and there's a necrotic area in this whole region. Yes? Any suggestions what to do now? You want to operate her?
Yeah, if we have any suspicion of cellular myoma, because this is a patient who already had recurrence thrice with large myomas, you may have to think about the possibility of a cellular myoma in this situation.
So we have thought of it. What would you like to do now?
So after counseling and getting the consent, I think we can proceed with the myomectomy.
Straight away. Okay.
Yeah.
Praveen, you're there? You want to talk? Dr. Praveen? He can't hear, I think. I can see him, but he can't talk. Suryak, any suggestion?
I think we have to do for the Doppler and for the LDH values to see if any.
The Doppler, LDH. Fine.
LDH. And then if possible, we can do a frozen section biopsy also when we start doing a surgery.
Frozen section from where? That's what I want to know. Or at surgery.
Necrotic part and cystic part, both we can take.
Do you want to do it pre-op biopsy?
No. Pre-op taking is of no use. I think we should do it intraoperatively.
Okay, fine. So what we did, we did a PET scan also. You can see the report. There's a large mass in the fundus involving the endometrial cavity, suggestive of malignancy. Is it choriocarcinoma or sarcoma to be considered? Minimal free fluid, no lymph metastasis. Is this a malignant mass? Possibility. So we went further. We decided we have to work her up because 2 myomectomies had been done and she's just 6 months married. You saw it was involving the endometrial cavity. None of you told me. So we went with a hysteroscope. That's the polyp which is sticking out. Unfortunately, the video is not very good. So we took that polyp, it's about 1 to 2 centimeter size, took it for biopsy, and my pathologist, to my horror, reported it as a stromal neoplasm. And very beautifully, they wrote all these numbers, do CD10, Ki67, cytokeratin, etc. for confirmation. Remember, she's a 31-year-old married just for 6 months. So to cut your story short, it's not in our hands. Sent to the oncologist. You all agree?
Yes, sir.
Yes, sir.
So we sent to the oncologist. The oncologist is the Cancer Institute Adyar. All of you know of the big center which does very well. They've reviewed the whole thing and they say it is dilated. It shows tissue with dilated endometrial glands, suggestive of endometrial hyperplasia with stromal predominance and focal glandular atypia. You can see the number of words which land you in trouble. I'm sorry to take you on this in a pure myomectomy dissection, but this is what happened in pure myomectomy. So they asked us to do the CD10, CD68, and the Ki67. CD10 is positive, saying it's possibly a sarcoma, a stromal involvement. CD68 is positive, and Ki67 all positive. And finally, they've told us very nicely to do a repeat biopsy. And they've told the patient, it does not look like a malignancy, but if you want, you can do a hysterectomy. So what to do? You're all the learned people. Let me know what to do.
I think, sir, since the diagnosis of malignancy is not confirmed from histopathology and immunochemistry, we will still give her a chance. We'll remove the polyp we'll just find out whether the cavity is good or not. If the cavity is normal, maybe we can tell them to go ahead with the cycle of IVF.
Okay, IVF with all this.
Yes, sir.
Okay, that means you're going to stimulate you. Jayashree, you're holding your head. Any objection?
It could be multifocal because we're not very sure what other part of the area of the fibroid she's having. Probably there is a it could be a leiomyosarcoma as well. I think we have to counsel her very well, and the better option from the patient point of view would be having a hysterectomy and leaving the ovaries back, and if she wants, she can have surrogacy with her own egg as well.
So your thing is, you want to be conservative or do you want to be radical? First question.
I would counsel the patient and take the patient into let her also. It should be a shared decision between the patient and myself rather than me asking for a myomectomy, because it's her life. Finally, we have to tell her the prognosis, everything, and let her finally come out as to what to be done.
Riyak, what would you like to do, radical or conservative?
Definitely, because she's married since 6 months, obviously the requirement of one baby is really required. So we have to think, if possible, to do a surgery and go for embryo transfer, or directly go for embryo transfer, and then. But we should have a diagnosis of what exactly the fibroid is. If it is malignancy, we should not miss it.
Yeah,
that is one big thing. But because all these medical legal problems are always there. Absolutely. So we can even plan for an open surgery. Why don't we plan for an open myomectomy? And then make sure that we don't have much spillage.
So she is currently waiting for surgery at the Cancer Institute, and this is the picture which we are going to get.
Controversies.
Yeah, controversy. Whether we are seeing forward or backward, we don't know. Is this man riding one motorbike or two? or is it 2 people, or what is it, is the question. And this is the confusing scenario in a myoma, which sometimes is absolutely irritating. I've been following this girl for the past nearly 1 month. Only thing I've collected is a big file. I still haven't got any answer to it. She's waiting for surgery and possibly will get operated. And I hope she will go to somebody else and not come and trouble me too much, no? That's the other part of the story. Okay. So with that scenario, let's go to just one question to all of you. All of you have been doing myomectomies. Can each one of you tell me one problem you did after a myomectomy, what you had by way of problem? Bleeding, pain, collapse? Anybody with patients with amenorrhea? I mean, infertility, I'm not going into it. Minupriya, would you like to tell us something?
Yes, actually, I had a patient. She had a fundal, or rather a cornwall fibroid. It was around 10 centimeters. So I had done an MRI for her because there was no other, she didn't have any complaints as such, only that she had a mass per abdomen. So I did an MRI for her. There was no other feature. It was just a cornwall fibroid without any degeneration. So I went in thinking of a myomectomy. She was 35, she's already completed her family. So she was opting for a myomectomy. I went for it. I was starting to peel it out. It looked like a para-ovarian cyst initially. So I thought, okay, we've missed it. It's a cystic fibroid or a para-ovarian cyst. I've started doing my myomectomy. And then I could identify that it was coming from the pelvic side wall. It was stuck to the pelvic side wall. So then we went and dissected against the pelvic side wall. It started bleeding horribly. Then I called my surgeon also for help, and he also came, and both of us we did together. It was basically coming from the iliac vessels. So, and it was very vascular. So, and we took it out, we did an in-back morcellation for her, and the histopathology actually came as an epithelioid hemangioendothelioma. So I've not heard of such a thing. Yeah, but
anybody else would like to recollect any story? Yes, Sandeep?
Yeah. I had one of our staff actually. She was around 45 years. And she was having infertility and was planned for IVF. So she had a 5 into 5 centimeter fibroid, and the infertility specialist, he had sent me for myomectomy. So unfortunately, that lady developed cardiac arrest following vasopressin injections. So this is the first case actually I have seen in my life, and we revived the patient, and then there were a lot of fluid in the abdominal cavity. So I just wanted to suck it out, and then anesthetist said, "You go ahead." Then second time she developed cardiac arrest, but without any vasopressin second time. So somehow the patient somehow she came out, she survived. So that was a horrible experience.
So these are problems. Yes, George, any story you want to tell us? No stories?
Bleeding. I mean, recently we had one, I think she was around 24, 25-year-old patient. She was a doctor. She, again, like the case that you described, she had previous one myomectomy. Within a year, again, she developed a huge broad ligament fibroid mostly. And we started operating, and then basically we couldn't get a proper layer. We couldn't really hold on to the fibroid. Wherever you're cutting, profusely bleeding. So because the whole appearance, it didn't look very benign. We had doubt. So we just stopped at that point from whatever we can take out. We took about probably 1/4 to half of it, and then controlled the bleeding and stopped. And when we are looking at, waiting for
a malignancy or?
The histopath, it was not malignant, but I think it came as cellular myoma.
Oh, that's a problem. They never commit here or there. Jayashree, would you like to tell us any stories?
Yeah, thinking that it's a fibroid, actually, when we're trying to do a myomectomy, it was invading back to the retroperitoneum, and there was a small connection with the uterus only. And finally, she had severe bleeding from the retroperitoneum, from the sacral vessels too. She was bleeding, and somehow we have managed to save the patient, but the report came as schwannoma. It was not actually a fibroid.
Oh. Lucky. Anybody else want to say any other story? Otherwise, I'll have to put.
I had another case, sir. She again with vasopressin. So our anesthetists are a bit reluctant to give vasopressin. So I was constantly having a fight with them. And ultimately I gave 20 units and 200 ml saline. I gave the entire around 120 ml I gave. Patient went into sudden arrest, and postpartum she developed a stress cardiomyopathy, and she was in the ICU with the inotropics for around 2 to 3 days. And it was such a stressful time.
Okay, so all of you have had problems, and I know all of you are good surgeons, but the important message which you're all giving us is one has to be careful. So I'd like to conclude, because Ashwath has started showing his face in the thing. I'd just like to conclude that in the management of myomas, choose carefully, plan wisely, operate correctly. That will result in a happy patient and a happy doctor. And I think that our panelists have done very nicely. Thank you all for your participation. I thoroughly enjoyed it. And all I want to say is, I'm sorry if I put you in a difficulty, because some of these are not standard cases, but you don't come to in a panel for standard cases. I think the important message we should take is, let's spread happiness with our endoscopy by doing good. So be doing good. And if you see this little fellow take a picture, how beautifully he's taking it, and you can see his beautiful camera, it only adds to the beauty of this whole scene. So thank you, KFOG, thank you, Ashwath, and thank you, everybody, for having me here. Thanks.
Yes,
thank you, sir.
Thank you, sir. Thank you very much.
Like, these are very rare.
Thank you.
Yeah. Can I just have a word? Yeah.
Yes, Sandeep.
Yeah. See, actually, cystic myomas, the technique that you have shown, like, it is really good. I think it will help a lot of, in our surgeries. Most of us, I think, will be benefited from this. And that last case was really, like, confusing. So that also has given a good message, like, what should be ready with it.
Okay,
thank you, sir. Thank you.
Thank you, Kurian sir, and the whole panelists, and especially Kurian sir. The panel by Kurian sir will have lot of new things and new messages for the youngsters. And sitting in a panel, you are all privileged to sit with the Kurian sir in a panel, means you would have learned a lot. And thank you, all your suggestions, excellent. All you showed that you are all great laparoscopic surgeons for the future. So with this, even at the end of the day, also 150 people are still sitting and watching us. So it is only because Kurian sir and you all, that is the only reason why they are all without leaving their dinner and sitting in front of the. So thank you so much, Kurian sir. As usual, we will be calling you again next year also. Next year we will be having a live workshop with all. So block your dates during this time next year. So we will like you to be in Kerala, okay, wherever it is. So thank you so much. Thank you, everybody. Now I invite our hero Subash to conclude and give the vote of thanks. Subash.
Yeah, sir. I thank you very much, Kurian sir. As usual, no words. Thank you, sir. Right. At the outset, let me thank the organizers for giving us this wonderful opportunity, to Ashwath sir and for me, giving me a good opportunity for this wonderful endoscopy workshop. Let me thank the president of K4G, Dr. Ambuja Madam, Secretary Venu sir, incoming President Ajit sir, and the whole team for giving us an opportunity and putting the faith on us for doing this wonderful workshop. I think we have done justice to our. I would like to thank all the senior faculties here, Dr. Hafiz Rahman sir, Dr. Paul sir, Dr. Kurian Joseph sir, and Dr. Krishna Kumar sir, the president of IAG, who has considered for all. Thank you very much, sir. Again, I would like to thank KJK sir and our friend Sujal Munshi from Ahmedabad. Thank you very much. I would like to thank all the panelists, starting from senior Jayashree Madam to Minu and all, Sandeep, Syriac, Praveen, and the whole team, and George, for the whole team for this wonderful work. I would like to thank all the chairpersons, senior most chairpersons, Dr. Sam Abraham sir, Dr. Hari Prasad sir, Dr. Ajita Madam, Dr. Usha Madam, and the whole team for this. Again, I would like to thank the organizers, the Metcon event, for this wonderful coordination. Again, I would like to thank CIPLA for their support. Of course, I think last but not least, I think I have to convey my special thanks to Dr. Atulya. It is her first appearance as a master of ceremony. I think Atulya have done wonderfully well. She called me up yesterday and said, sir, I'm actually very nervous. I said, don't worry. All the people here are to help you out. Thank you very much, Atulya. She's finally a postgraduate at Jubilee Mission Medical College. And I wish you the very best of luck in all the future activities also. Thank you very much. And thank you all great faculties for obliging to our kind request and doing, I'm sure we have done justice to our the work that was given to us. Okay. Thank you very much, Ashwath sir, for all the coordination, for all the work, sir. Thank you, sir. Thank you. Minu, thank you, Minu. Minu ne marnoi. Sorry, Minu. Thank you.
Thank you.
Thank you, sir. Thank you.
George, how is Dubai?
George, the mute, unmute.
Dubai is good. Nalla, wonderful climate. It's not hot here.
And Corona, how is Corona in Dubai? Restrictions are there?
No, not much. Corporal, not like how it used to be, but it's not bad. Doesn't look like the place is.
You're becoming thinner.
Pardon?
You're looking thinner after going to Dubai.
Definitely. Hogging every day.
Good. Okay, bye.
Okay.
Good night.
Bye, everybody. Bye, Atulya. Bye, Priya. Thank you very much, Atulya. And George.
Thank you, sir.
Thank you. Thank you. Yeah. Thank you, Medicon. Thank you, Arun. Thank you. Thank you, Sam, sir. Everybody is here. Thank you. Thank you.